Welcome. Keep looking for a microphone to turn on. It's going to take a while. The agenda item number 1, approval of the minutes. I'll entertain a motion to approve the minutes of the July 18, 2019 public meeting of the commission. We did not meet in August. Do I have a motion to approve the July 18 minutes? Commissioner, second was second. Commissioner O'Connor. Discussion. All in favor?
Aye.
Opposed? Is there anybody on the phone? No? Good. All right. Go. Thank you. Agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Yes.
I do. I just have a question. If we were anticipating a amount of money to go for our call payments to be close to $5 million.
Total
January to June. And should we anticipate another $5 million for the second half of the year?
So, without having the numbers right in front of me, on-call has been accelerating as a share of the total allocation on trauma funds payouts. I believe in FY 2019, it was about 8 of the $12 million. I'd have to look at this closer. I'd be very surprised that it would be basically absorbing the entire allocation from the Department of Motor Vehicles, which is what that would say. So
change that you have more people working on collection.
So
what's causing that?
part, I think there's greater awareness on how to tap into the on-call payments on the part of the level 2 and level 3 trauma centers that are largely eligible for on-call. There's also an automatic escalator in the payments based on the care economic index. Everything else being equal, it's going to increase by a couple percent, which is obviously in 1 year is not going to drive things forward, but cumulatively over time has been an accelerant on that spending. But yeah, I see your point about the 4.9 million in on-call. That seems to me to be about $1 million higher than I would expect in a 6-month period. So I'll have to get back to the commissioners to clarify that.
It's a lot of money, and it's as a result of the taxpayer. They intended to pay for uncompensated care, and a $5 million, practically $5 million bill at the backs of the taxpayer who is just trying to register their vehicles. It's a lot of money.
So yeah, that would be as we move forward, rethinking of the trauma fund. What would be the appropriate funding on call is one of the key questions. Remember that talked about this a couple of times in the past. When the fund was established in 2003, there was a desire to have parity between uncompensated and undercompensated care, Medicaid payments, and trauma centers, largely 2s and 3s, that had very significant physician availability costs, standby and on call. But over time, as health systems have acquired physician practices, the fact that they're paying retainers to physician practices is largely been mitigated in many instances. That the surgeons that are working at those trauma level 2s and 3s are often on the staff. But the on-call payments have continued. The hospitals can document on-call hours, and consistent with the statute, we pay them as part of the report that's due to the legislature. This fall, we'll raise questions on maybe how, at least the pace of spending for on-call ought to be slowed.
It seems to be like the cost of doing business for hospitals to have people on call. But I mean, I can understand it for making up for the uncompensated care, but.
So it's a little bit true and not true in all of that. So first of all, the physicians in 2019 don't take call for free. And the cost of hiring physicians to take trauma call is much higher than the cost of hiring.
$1,000 a day, right?
Varies tremendously. It can be at a level 1 trauma center for orthopedic trauma coverage, $3,500 a day. At level 1 trauma center around the United States can be, there's just tremendous variability. But this doesn't even come close to covering the actual cost of doing that. It covers, it supplements that cost. But I can tell you that for many of the level 2s and 3s around the state at this point, given the national costs of those services, they wouldn't be able to afford to have people on call. So while you would be providing Medicare rates for the services that people provided, there would be nobody to provide those services. Because the process of taking call is in fact very disruptive to a practice and not something that you can do and have an elective practice at the same time. And even in the pure trauma practices, there's just not a way to generate compensation schedules that are competitive nationally and rely on collections, particularly in Maryland. There has to be the additional money. So yeah, I get it that the idea was to provide uncompensated care, but you have to provide care for individuals without compensation. That means you have to have somebody on call to do it.
I'm just pointing out that
It's a lot
$5
of money.
million for a 6-month period of time is a significant amount of money for a fund that has an overage generally around 11,000.
The last several years,
Let me-
our appropriation, which is based on $5 allocation from car registration and registration renewal fees. So we get about $12 million per year.
$2.50 a year for vehicle registration, the number that hasn't changed since, a flat number that hasn't changed since 2003. So I think we're still providing value for it, at least the same level of value that's provided.
But in that period of time, a lot has changed as well in
That's correct.
regards to insurance companies and individuals being mandated to have insurance. So that's where we saw that dip and the overage.
Well, I would say just one sidebar on that is that there's going to be, again, this kind of issue coming up. We have the ACA, the rate of uninsurance has dropped. It's popped up a little bit in the last few months. But there is all that infrastructure that we put in for uncompensated care. So this same, not these specifics, and you have a persuasive answer for what's going on there. But we're going to, any of the kind of clinic care, any of that stuff where there was kind of a sort of a lump sum payment coming that wasn't tied to a patient seeing a provider or whatever, a claim. I think it's just, I wouldn't be surprised if we'll see the Assembly and the Senate kind of scrutinizing those, because that's, if you used to have 15% uninsured and now you have 7, where's that money going? It's just going to be a logical question for the budget.
The money came out of the rate structure.
Yeah, and
So it's,
I'm
that correction has already occurred.
oh, okay.
It's
Okay.
since 2014.
Can I bring up one issue in terms of before we move on?
Sure.
I see that on the kind of housekeeping stuff, you have the hospice data is coming up. I'm very happy to see we've got hospice on the agenda for today. I would like to ask, and it looks like the new data is coming out. You'll be ready to discuss it next month. I would like to see, as just part of that, I'd like to request that we see that county by county breakout compared to what we think our benchmarks are from the national data of what the penetration should be, because hopefully we're seeing very good PG County and Baltimore kind of potentials, if not already there. But I think we still have some underserved sections of the state, and it would be important to see sort of where they are. Thank you.
Other questions? Does the executive director or any of the center directors have additional update? Ben?
So I have several updates I want to bring to the attention of the commission. informed you on several of them previously. First off, as you know, in the 2019 session of the legislature, the Senate and House approved the establishment of a drug affordability board and allocated $750,000 for the establishment of that board in 2020. The governor has requested that NHCC assist the administration in establishing the board. The board is charged with monitoring drugs that cause affordability issues and was appropriate to conduct cost reviews on why acceleration is so rapid. And there is the potential to set payment limits on certain drugs that have triggered affordability issues. There will be a process in place that the board will have to go back to the legislature and explain how that would be done in future years. As I mentioned, the legislature also allocated from general revenues $50,000. In Maryland, it is only the executive that can allocate funds. And over the last month or so, there's been a debate within the executive and legislative branch on how the board would be funded. Given the strong support of the administration for the establishment of the board, but the desire to preserve executive branch prerogatives, they've asked us to come in and help establish the board. The board is composed of 5 members, one appointed by Governor Hogan, one appointed by the President of the Senate, one appointed by the Speaker of the House, one board member by the Attorney General, and the final member in collaboration by the Speaker and the President together. Some of the members have been named. The Speaker and the President have named the Chair, who is former Secretary Van Mitchell. And so, the board chair has indicated that he wanted to get started. The administration has asked us to help with the establishment in FY 2020, which we have agreed to do, being part of the executive branch of Maryland government. What we would be doing is working with the chair and members in staff hiring. We probably would be responsible for placement of any staff that from the board that would work in 2020. We would, to the extent possible, if we have some expertise and availability, make some of the staff available if there was a need. We have the most important information resource for examining drug spending, in that the pharmacy component of the APCD will be the primary data source for examining affordability. So it makes sense that all the agencies available would take a role in that. But we have advised the governor's office that our resources are limited. They will be allocating to the MHCC temporarily some of the PINs, patient identification numbers, authority to hire for 2020. And we'll move forward. I expect to brief you further on this in some of an email I sent you all this morning. I did provide a fiscal note on the legislation, which does provide, as well as the cost of the program, a good overview of what the requirements are. So if you haven't had a chance to take a look at that, please do at your leisure. Secondly, last month we talked about the commission potentially playing a greater role in the administration of the Maryland Primary Care Program. Legislation passed in 2019 required us to issue, in collaboration with HSCRC, a report on the funding for what is called the Program Management Office of the Maryland Primary Care Program. We have talked with the Secretary and HSCRC on several occasions. It is a strong preference of the Secretary that the two commissions in collaboration with the department move forward with a spending plan for 2020. The chairs of both commissions do have some questions outstanding regarding how the PMO, the Project Management Office, would be directed. A three-headed monster usually doesn't lead to efficient oversight, and we do have a meeting scheduled with the Secretary of Health. But in the meantime, we have the requirement to get back to the legislature to explain our plan. HSCRC and HCC sent a letter to the joint chairs yesterday outlining the broad skeleton of a plan for 2020, with the qualification that we will continue to talk with the Health Secretary on putting further structure on the program. The primary care initiative has been historically very important to the Healthcare Commission. David Sharp's group has worked closely with primary care physicians and non-physician primary care providers. It's important to recognize that when the first primary care program was launched, we said we were trying to obtain 50 practices, and more than 225 practices applied. So we certainly have the ability to recruit practices, and I think that expertise is there for providing some oversight as well. But we'll rely on the Secretary for his input as well, and keep the commissioners posted on how this program evolves over time. Third, in your update, I did mention that we had been informed through the payers that OPM had instructed them to cease and desist in providing federal employee and federal retiree claim information to all state, all payer claim databases. All 18 of them would be no longer able to receive federal employee claim data. This is a significant impact on the Maryland all-payer claim database. The federal employees represent between 20 and 22% of the covered lives in our data collection effort. And this reduction significantly compromises some of the directives we've gotten from CMS, specifically CMMI, that we use the all-payer database to monitor impacts of the new total cost of care model on the privately insured. So on one hand, the federal government is saying, do this, but on the other hand, another arm of the federal government is saying, we're going to literally poke out your eyes in terms of this assessment. I think we have something of a disconnect here. We have talked internally. I have alerted the governor's office that this could be a problem, and we are considering whether we make our appeals to OPM, specifically to Maryland, engaging CMS as a supporter for continued participation of federal employees in the APCD, or if we work in collaboration with the other 17 APCD states to try to affect a broader change of policy. It's my belief that we should probably do this on our own. Maryland is the only state that has a total cost of care model, and only state that is required by CMS to demonstrate impact of a CMMI demonstration on the privately insured, and we likely would make better headway in that direction. We have begun some discussions with several former OPM employees on guidance they might provide in terms of approaching the Office of Personnel Management, and we'll develop a strategy and share that with you before we move that forward and get commissioner input.
What's the reason they provided?
They did not provide reasoning, and this was, although we were told every payer has contacted us, a major payer that has participated with us, CareFirst, Aetna, United Healthcare, and Kaiser all said they have been given this order by OPM, but no one seems to be able to say why. Recall in 2015, I think maybe Dr. Thomas was the only one here at the time, that there was a determination that OPM was not going to consider, didn't want to do this any longer. We then, working with leadership at OPM, got them to relax that requirement for Maryland. So it may be that leadership at OPM has changed. We don't have, it's probably good not to speculate until we've talked to them as to why, because there are lots of reasons that could be the explanation. Lastly, we have, I know there's considerable interest in our assessment of healthcare services in rural areas. One particular focus has been on the work that we have been directed to by the legislature in Kent County. We have awarded a contract to LD Associates to conduct the assessment on the change in the level of services provided at Shore Health Chestertown Medical Center. That work is underway, and we're confident we can meet the reporting requirements in the legislation to have that ready by January 1st, 2020. We will be meeting with elected leadership in the county to explain approach. We have one other procurement we would like to do, and that would be to develop a vendor that would work with us to identify the blend of Maryland total cost of care components and national rural reform elements across the country that might be appropriate for rural areas of Maryland. That contract is still under development, and I hope to have some good news on that in October, because I think simply explaining what happened is not going to be sufficient for the legislature, and we'd like to give them some meaningful options on what they ought to consider. Left to their own devices, sometimes they can pivot in one way or another that leads to some unproductive outcomes. And lastly, given a rather dismal or sort of pessimistic review, I wanted to note on a positive note, Commissioner O'Grady mentioned it earlier, that on the 10th of September, the U.S. Census released the latest health insurance coverage results in Maryland, or in the U.S. for plan year 2018. Maryland's uninsured rate actually, statistically, it was flat. It did nominally decrease from 6.1% to 6.0%, but it was not statistically different. It still means that approximately 350,000 Marylanders were uninsured for the entire year. But that goes against trends across the country where nationally, from 2017 to 2018, the uninsured rate climbed from 7.9% to 8.5%, a statistically meaningful difference, which meant that uninsured in the country jumped from 25.6 to 27.5%. So that's something that we ought to all be proud of, and is kind of a recognition of the collaboration that has gone on here in Maryland that has kept us moving forward, albeit somewhat slowly, in reducing the number of uninsured. But wait, there's good news around the corner, because this doesn't really reflect any of the success we had in 2019 after the federal government approved our ACA 1332 waiver that allowed Maryland to establish a very innovative reinsurance program that I think will probably push the uninsured rate in 2019 below, certainly below 6%, and probably in the area of 5.5%, based on the estimates we have on what the Health Benefit Exchange accomplished in 2019. So that's definitely good news, and definitely a reflection of the great collaboration that exists here in the state. Any questions?
Commissioner Brady?
Back on Drug Affordability Board, so there's only one of the 5 members who's currently been appointed.
I was afraid you would ask that question. I do have all the board members have been appointed, with the exception of Governor Hogan. I'll have to get those names to you. But,
Okay, thank you. And then the 750,000 doesn't sound like a lot of money really to like set up a whole new organization. Are you thinking you would simply have current staff do that, or are you going to let this out as a contract, as a support contract for someone, a contractor to come in and provide, kind of the startup?
So I think the allocation that the legislature made was for 5 employees, and work with the board chair and how quickly the board wants to fill those slots. But I emphasize to the governor's office that we have
Yeah.
part of the staff to
Right.
help them. We certainly want to build some synergy between the APCD drug information and work that the board is doing, but we can't deploy 2 or 3 staff members to.
Well, that's what I was sort of thinking. Would they prefer to have somebody who sort of is, like one of the vendors we use that is sort of fairly data heavy, but also could help them with just kind of standing up the organization without expecting our staff to do all their regular duties plus.
I think that's a question that's the board chair probably would make a call on. I've given them advice not to hire 5 people in the span of 2 months.
Right.
My experience from working at nascent organizations is that you invariably make mistakes, and to spread it out would be better.
Right, yeah, exactly. One that having dealt with when I was a Fed with OPM a lot over decades, it may be quite possible that CMS and OPM have not really talked. They don't, it's not something that happens a lot. I think the actuaries often talk more than any policymaker does. So some of that, certainly your idea of touching base with CMS, letting them know that an OPM decision is putting at risk one of their major projects. I mean, it's upsetting us because it's our major too. The other thing I guess I would suggest on this as a step 2 would be the Maryland delegation. OPM has a very great aversion to having to go up to the Hill and explain themselves. And so,
In particular, something that doesn't seem readily explainable.
I'm going to have a hunch once you start talking to them. It's just, they looked at it, it cost them $300,000 a year, and they got a tight, budget, and why, they get nothing from it. So, and their first offer may be you pay the $300,000 and no problem, but we're not paying it anymore. So it could, and I'm totally projecting, but it's just, they are a very operational group. It is more like an insurance company than it is the way we think of CMS. So it is just, they'll have an answer, but it's quite, it's driving us crazy, but hopefully it is easily fixable in terms of, especially with a little, GS15 at CMS calling GS15 at OPM has often removed the roadblocks, just,
But you're right, the delegation would have a lot of influence here.
The delegation will be, and that's sort of your ace in the hole.
Yeah, well, it's
The
even more
Fed
than
to
ace in the
Fed, they
hole.
can work it out, but
It probably is incumbent upon us early on to make sure that they're briefed on this issue so that they
sure.
don't early.
And we will work through the governor's legislative office in Washington to
Perfect.
get those contacts.
Perfect.
I think my preference would be to sort of get a lay of the land before we bring in, bring this.
Yes, I'd say that's sort of your round 2 strategy. Because if it all it takes is a phone call from the CMS administrator to say, I need an accommodation.
Senator's chief of staff.
Yeah, however you want to do those things. But
Relatively low level things.
Right. And in a very bipartisan way, but I'm sure that all can be, it's just, this doesn't seem like it shouldn't stand. Okay, Good. And then on the uninsured, do we have, I mean, to a certain degree, what I don't know on the uninsured is it's sort of like unemployment, where there's sort of, there's like if you're 3%, you're really at zero because there's like, college kids over the summer and stuff like that. So the ACA, there's certain things that like, and I don't mean this as sort of a illegal immigrant thing, but non-citizens don't have a lot of access. And, certainly down in the DC area, we have a lot of, we have a lot of diplomats, we have a lot of people, living in Maryland, but they're not, but they're expats from wherever they come from. So it's those sorts of people. So do we have an ability to, once this data is, to kind of cut it a little bit and get a feel for if we still have, what did you say, 300,000 people or so?
360,000.
Yeah. So how many of those are realistically,
Insurable.
Yeah. So if you tell me the 200,000 are some combination of, people who work for German drug companies or, and live in Bethesda, I'm not going to worry about them. If you tell me we still have some extremely poor people who are in trouble, think about it.
That's not the group anymore, because with the Medicaid expansion, what we really got is that working poor group at the edge.
Yeah.
The really poor, we've taken care of.
Right. But it would be great.
We've provided access for it.
Yeah.
Not all of them have actually signed up for that access.
Sure.
And some of that 360,000 number is going to be people who are eligible, but just haven't.
Yeah. But it'd be great to see it, at least like a one-page, to give us a notion. You have 6 left, but really 3% really is kind of off the table. So your real number is 3.
It sounds like a good opportunity to collaborate with the Maryland Health Insurance Exchange, because I think their board members probably would have the same question. So we have,
We hope so.
and it's my recollection that the CPS, now it goes back slightly, different term in the current population survey, which for March, which is the source for measuring this, doesn't distinguish aliens with and without documentation, which.
No, they just asked were you born here, and then another question asks you, do you have a green card?
Well, the assessment that you're asking for is probably very valuable to the General Assembly as well, if it's not already available. But that's something that we really should.
Right.
I think you're right. We should have.
Okay. Thank you.
Commissioner O'Connor.
What's the authority of this affordability board? Do they have any power? If they just not sure are drugs unaffordable,
Well, there's a glide path into that affordability that this was much like the way that Maryland Health Benefit Exchange was established. This first step is the establishment. There are reports that the board is to make back to the legislature in terms of funding, in terms of how they would propose to establish affordability ceilings that have to be anointed by the legislature going forward. So you might look upon this as really the first step. I'll be happy to provide you with the 50-page statute, but probably be more valuable for me to give you a summary, which I'll try to do over the next month as we temporarily be engaged. I don't anticipate permanently being involved in the board. This is a stopgap measure.
But yes, the language about they're going to set drug prices or cap. I think there's a Supreme Court,
There will be a lawsuit before this board gets launched.
All right. Other comments, questions? Hearing none.
So absorbing 25% of the commission's time on my update, I offer apologies. Try to keep it down in the future.
I'll move us through the rest of it. All right. Agenda item number 3, action, certificate of need, Baltimore City General Hospice Review. Bayada Home Health Care, Carroll Hospice, Inc., and PB Health Home Care Agency. The commission established review cycles in 2016 to consider proposals for new general hospice service providers in Prince George's County and Baltimore City. These jurisdictions were determined to be eligible for consideration of expanded hospice service capacity based on state health plan policies that target jurisdictions with relatively low levels of hospice use and relatively large populations. PG County review was completed earlier this year, and today we'll consider 3 CON applications for Baltimore City, 2 of which involve the establishment of new general hospices that will serve Baltimore City, and 1 proposal to expand the authorized service area of an existing general hospice to include Baltimore City. Commissioner Stephen Thomas served as reviewer in this comparative review and will present his recommendations for action on these applications to the commission. Commissioner Thomas, I believe you also have a piece of information to share with the commission and staff prior to the hospice review. The floor is yours, sir.
Thank you, Mr. Chairman. We don't have our mics. I guess everybody can hear.
It actually does pick up there, Mike.
That's
Yeah.
good. I think when I present my formal remarks, I'll move there so I can see my fellow commissioners. The mics work there as well.
They do.
But my preamble is this: over the weekend at the University of Maryland's Xfinity Center, we turned the home of the Terps into a house of smiles with 110 emergency dental chairs, wraparound medical and public health service. We served 1,089 people over 2 days, 1,500 volunteers. I say that because the word cooperation has come up several times as we talk. Things happening in Maryland that should be highlighted, including the kind of cooperation taking place in the state. There were 2 flagship sponsors, Kaiser and Cigna, competitors on the battlefield, set their sabers aside to serve the citizens of Maryland. And I interviewed some folks afterwards. First person in the door lined up at 7:30 p.m. And these people were in line for hours, and they left with smiles and tears of joy. And I interviewed a few of them to say, how is it that you could come into a basketball arena, spend hours, and leave with smiles and joy? I mean, what does that say about when you go into our traditional healthcare facilities? And you know what they said back to me? So when I go to those traditional facilities, the first thing is, you should have been here sooner. You should be flossing. And on and on and on, a lecture, a criticism, a talking down. And it dawned on me that no matter how much access we provide, once people walk through the door, they must be treated with dignity and respect, or it doesn't matter. And so these are the subtleties, the nuances as we make our decisions about expanding access to also focus on the quality of the people's experience. University of Maryland is 9 miles from the White House. To have thousands of people sleeping outside overnight for care is not something we think of when we think of the state of Maryland. And yet we do 4 of these across the state. I think there's an opportunity to listen to those folks, to link up with our total cost of care. Every one of those people live in a catchment, which means that we can communicate back to these health systems what we're observing. In addition to the dental care, there was comprehensive medical and public health services. So I just wanted to share that because it has implications for our work and also evidence that there are really promising practices here in the state of Maryland that we should also lift up.
Commissioner, please. I just want to note that you set the bar high when you have multitudes of people leaving the Xfinity Center with smiles on their faces. It sends a message to the Terps for the upcoming fall and winter. Hopefully they can match that performance.
Thank you, Mr. Chairman, commissioners. I'm going to present my review of the Baltimore City Hospice using Viata Home Care Hospice, Caro Hospice, and PB Health Home Care Incorporated. This comparative review involves 3 applicants that seek certificate of need approval to provide general hospice services in Baltimore City. Now, on August 28th, I issued a recommended decision in which I recommended that the commission approve each of these applicants. And I'll just take a thumbnail to share with you some background and context and then open up for comments and questions. One applicant, Caro Hospice, is a longstanding provider of hospice services in Maryland. The 2 other, Viata and PB Health, have been providers of home health agency services in Maryland. And Viata provides hospice services in 4 other states. Each was approved by the commission to provide general hospice services in the jurisdiction of Prince George's County. I want to note that Prince George's County has a 62% of Prince George's County's population is Black/African American. It's noteworthy as we move on. this March. So that was approved this March. And in applying to expand their authorized service areas to include Baltimore City, each of the three applicants is rated relatively high quality provider with regard to their respective Medicare government quality indicators. Now, Baltimore City population 65% African American. Has one of the lowest hospice use rates in the state's jurisdiction, it's only 29%, compared to 44% statewide and 48% nationally. And Baltimore City is the fourth most populous jurisdiction in the state, 600,000 residents. The combination of low hospice use rates in Baltimore City, large populations, means that there is significant opportunity for new providers of general hospice services to raise hospice rates in the city of Baltimore. Now, while there is no certainty that adding new general hospice providers in Baltimore City will raise hospice use rates, in how does the community respond to these services? What do they think about these services? How do they treat it when they come in for service? What's the word of mouth on the street about service? Approving these three applications will increase the jurisdiction's residents' access and additional quality general hospice providers. My initial review of the application showed that none of the three applicants was fully compliant with the charity care standard, and that each needed to submit modifications to their responses to other standards and criteria. To facilitate this, I convened a status conference at which I advised each applicant of the changes that needed to be made in order for my approval of its application. Each applicant submitted a modified application that met the applicable standards of the hospice service chapter of the state's health plan, and the general certificate of need review criteria is now approvable. Because I believe that adding these three hospice providers will reach the Commission's policy goal of increasing hospice use rates in the city of Baltimore, I move that the Commission adopt my recommended decision and approve the applications of Carroll Hospice, Viata, and PB Health to establish general hospice programs in Baltimore City with the following conditions on each of them. 1, prior to use approval, provide documentation of links it has established with hospitals, nursing homes, home health agencies, assisted living providers, adult evaluation and review services, senior information and assistance programs, adult daycare programs, the Baltimore City Department of Social Service, and home delivered meal programs located in Baltimore City. And secondly, that prior to first approval of use, provide documentation of the arrangements it has made for providing respite care to the families and other caregivers of patients. That's my initial summary, and with that, I'll turn the floor back to the chair.
Commissioner Thomas, you've made a motion. Do I have a second?
Second.
All right. Questions for Commissioner Thomas?
I have one, and it may be more to the staff. On the notion of charity care and establishing it and making it a real provision, do we have an evaluation methodology? Is there a follow-up? Everybody has agreed to this, as they did in the PG County case, So, but how is that verified a year, 2 years, 3 years from now?
Well, as I mentioned in the front end, the fact that they had to go back to the drawing board, so to speak, and clarify. So in writing, it's clear. Therefore, you're asking, where's the oversight?
Yes.
Who's responsible for the oversight?
Right.
I'm going to look to my attorney assistant.
Yeah.
Sue Ellen, do we have authority of this body or some other body that provides the oversight to ensure that the charity care standard is indeed implemented?
Each home health agency and each hospice in Maryland fills out a survey each year. There's a hospice survey in Maryland.
Okay.
And they provide information annually on that. The commission puts that information eventually on the commission's website. There's a public use data set where that can be looked at. And I assume that if an approved hospice does not meet the charity care standard, that which they promise to do, if they don't meet the minimum required, that staff will send them a letter, and they might be called back in before the commission to explain themselves. This is typically what the commissioners want.
Right,
They can do
oh,
it.
definitely. So, but that's our jurisdiction. It's not going over to the state health department or anyplace else. The survey and then the follow-up is us.
That's us.
Good.
Before you leave, Sue Ellen, would you say that it has teeth?
It has teeth if we want it to have teeth, and I'm getting the feeling that the commissioners want it to have teeth.
Indeed.
At least a couple.
We'll send it back to the Xfinity Center with more teeth.
You know, I mentioned the proportion of the population in both Prince George's County and Baltimore City. The reason I note that is because at a certain point, it's not just access, it's also tailoring the message, it's tailoring the outreach. And we're at that stage in these two majority-minority jurisdictions. This is a challenge across the country. If any place can do it, we can here in Maryland. And this is an opportunity to hold some feet to the fire, have both guidelines and assistance, but also teeth and observations and oversight to make this work.
So, other questions? I have a question. So we started off with a recognition that we've got problems in Prince George's County and Baltimore City, two very big jurisdictions with hospice utilization rates in the 20s, 26, 29, I think, respectively, and a mean statewide number of 48, 49, but some big jurisdictions with numbers in the 60 range. And our solution to that problem was to increase access, hopefully to increase utilization of services, but we have information that there are cultural barriers also. So what are we going to do do we have a plan in place to monitor the utilization rates of hospice services and to intervene with other programs to increase utilization rates?
Well, we've made the recommendation with caveats, and I've mentioned two of them. And so before as we call it here, the actual prior to first use approval, they must document that they have built relationships with organizations that we know in advance have trusted interactions with the very populations we're trying to reach. And so we're going to allow for their own creative imagination, not to tell them what to do, but to point them in the right direction. But they cannot begin until they have evidence of these partnership organizations, and then also in the prior use approval to provide documentation that they're addressing the needs of caregivers. Another very, very important aspect in the hospice arena, respite care for the caregivers. So we will watch very closely how they do this, but they have been given guidance and directions, and we've heard now we have oversight with some authority to ensure that it happens. I don't think failure is an option here. For many of these populations, there's a lot of fear. In my own personal experience, if I can mention hospice for my own family, but it was the last thing we did. We came late to it. When we finally got it, we were glad we did it. When it was over, we never told anybody else. So word of mouth is important. So when people have a good experience, we need to make it okay to talk about it. Simply because grandmother had hospice doesn't mean we did not care for her, or we did not love her. These are cultural dynamics that I think that all three of these organizations will benefit from learning from these service providers that every day serve this population.
Yeah, I don't mean to beat this dead horse, but I think this is critically important because there have to be some examples around the country of organizations that have successfully dealt with these cultural barriers and effectively increased the use in difficult populations. And it's when we look at the challenges of meeting the total cost of care objectives, addressing the use of hospice is critically important. We're not going to get there without addressing the use of hospice and addressing the use of hospice early on. So I just think it's going to be important for us to continue to think proactively about ways to address challenging populations.
Well, and if I was to predict, next month when we see the state level data, which is why I asked for county breakouts, we'll see that our last holdouts of, 23% in a state that's at 45 are going to be those Appalachian counties, because that's what they were there last. Now that's a different dynamic. That's going to be a, how do you efficiently provide hospice where
It's an access issue.
it's an access, you're going to need more than, you're going to need more providers. It's going to be but your same notion of, is there a kind of best practice out there? There's something to learn from Montana. They deal with, it'll be a different barrier that we're trying to break down. Our tools, again, will probably be increased access by having more providers if that's possible. But again, we do need that best practice from probably outside the state, because clearly we're not doing the job in Maryland.
Well, it may be that there aren't best practices out there. That if you look at cities like other cities and other jurisdictions with large African American populations, that the penetration of hospice is still very low. Maybe it's an opportunity for us with an organization like this to put together a grant program to encourage people to be creative about proactive ways to.
Mr. Chair, I think that's an excellent suggestion again, because we have policy alignment in the state of Maryland that incentivizes doing this right.
Yes.
With my academic hat on, we typically do a comprehensive literature review to determine what are those best practices, and still may not find them sufficient for our needs. If there is a best practice that could maybe serve the nation, it's highly likely it could come out of Maryland because of our policy alignment.
Commissioner Jordan.
Yeah, Steve, I commend you for all the hard work of the staff in doing this. I would ask the question though, the requirements that you're suggesting that we put on these 3 hospices, are there similar requirements that we put on the rest of the hospices that have come forward?
That's a good question. We defer.
You know where I'm coming from.
Yes.
We want to make sure that we are not doing anything differently.
It's consistent. Thank you.
Because how many others are there?
Well,
We just did Prince George's.
Prince George's has these kind of conditions. Kevin, can you speak to this? Kevin? Mr. McDonald?
yeah.
These are pretty much standard conditions.
So they're standard conditions. This is not something exceptional. Oh, okay.
No, I
I'm
think-
just curious.
I think what's being is that there's clearly a policy interest in this. And so it's within our portfolio to do, and there's an encouragement from at least a couple commissioners, let's really review this. Let's really make sure that this is happening. And that if there's something stumbling here, let's get in early and fix it, and anything we can do to help. But there's nothing uneven in terms of everybody does face these standards, but they do need to be enforced.
This is no different than any other hospice.
Right.
Martin, there are times, Martin, when you have the teachable moment, the teachable moment, and this was our teachable moment with these 3 applicants. It's an opportunity to reinforce what are our standards, and then ensure that as they move forward, they have the guidance and they know there will be the oversight.
Yeah, the only comment I wanted to make, we talked about the hospice and the home care component, which is so important. We've all had experiences, unfortunately, in our life where we've had to work with hospice, and there may not be a home care component that's acceptable or financially viable for that family to bring in. I mean, hospice is only a small part of the care when that patient is dying at home. And so I think that's where the hospital, through maybe the all-payer model, where we could start looking at incentives to give healthcare providers incentives so they can allow these families access at a reasonable cost to continue to provide that care so these patients can stay at home. But the home care piece, when I talk to hospices, they tend not to want to get into that market for some reason. They sort of say, well, we do hospice, we don't do home care, but it really is kind of a similar thing where you really need to coordinate that. And a lot of them don't step into that territory, and these patients are left out there where you need hospice care, but there's nobody to follow up on a day-to-day basis after hospice leaves. So I think there's a lot of work we can do by providing those incentives where those patients can get both components together and take care of them outside the hospital.
We've seen other examples where this commission has Commissioner Pollack mentioned different grant programs, allowed for innovation allow for discovery of new models, that would be a very good opportunity at this stage.
Commissioner Boyle.
Yeah, I'd like to better understand what the payers, like Medicare and Medicaid, pay for hospice, and where does charity care come in? So how much is paid by traditional payers and how much is needed?
Kevin?
I'm sorry, I didn't hear that question.
What percentage of the cost of hospice care is typically covered by payers? And distinguished by payers.
Medicare is the primary payer.
What's the patient's obligation?
Yeah, and
As a percentage.
where does charity
80-20?
care really come in?
Share of hospice charge.
That's my understanding.
In general, charity care is a very small percentage because Medicare is the primary payer and Medicaid also covers hospice.
The overwhelming majority of
What
it,
is the cost sharing on it?
almost none.
Is it like DME where it's 90%? Is it like a regular office visit where it's a 20% co-insurance? What is the split between Medicare and the beneficiary on paying for hospice?
I don't have the specifics, but Medicare covers the vast majority.
Right. So I think what you're saying is this a low-income Medicare person, but maybe not Medicaid? And therefore, there still is an outstanding bill, and is that what we're thinking of day to day
Is
as
that a
charity
barrier
care?
is the question.
Yeah.
So-
Primarily having the policies in place to deal with the situation.
So let me just cut the conversation short since we don't have data on this. We can come back, we can get some information about specific numbers and bring it back to the group. It's not really, let's get,
Yeah.
I'm gonna try and, it's a fantastic conversation, a fantastic discussion that we need to have, but I want to get back to getting through this particular COA. Commissioner?
Steve, is there a lower limit of utilization requirements for the hospice where they need to maintain utilization above a certain level?
Are you asking if we have placed that standard
Is there
on them?
stipulation in there?
They don't get a certain level, they won't go out of business because they won't be able to afford to stay in business.
Not one that
So
we've
they'll
said.
self-limit themselves?
Right. I don't think the statute has a minimum percentage necessary to maintain.
Like, we looked at other like cardiac services.
That's
If
correct.
There's a threshold, if they go below it.
I'm not aware of a
There's nothing
similar
like that.
threshold, no. Jeff?
Thank you for the work on this, Commissioner. Not so much a question, more an observation. We're talking about expansion of hospice versions within the CON, and that's Commissioners demonstrated is probably all well and good. But as the commission looked at the hospital referral process, as we talk about utilization of hospice, I mean, have we reviewed that at that level? Because that could be an impact on utilization.
So the theory behind that issue, I don't know that we have specifically looked at that. But the theory behind that issue is that under the total cost of care models, the hospitals are significantly at risk for patients who are not in hospice care and wind up readmitted to the hospital. The penalties are huge. So the thought is that the total cost of care model addresses that incentivization of the hospitals to make sure the referrals are effective and efficient.
Thanks.
Very good example of policy alignment.
Yeah.
That doesn't exist in other states where we can address this with this particular population.
That's absolutely correct.
So do they come under GBR money, these hospices connected to hospitals?
Well, they come under GBR because if a patient goes home with a terminal diagnosis, not in hospice care, and gets readmitted, that's a penalty to the hospital that discharges the patient under GBR. So that's a direct example of one way in which the total cost of care model directly incentivizes the hospital to get it right. And those
The
penalties
hospitals don't have a rate setting.
No. It's the hospital, not the hospice that's under the GBR, not the hospice. I misunderstood your
And
question.
you can see why that handoff is so important. If they miss that handoff properly and the patient's back, they're penalized. So again, policy incentives that increase the likelihood of getting this alignment. Now, there still can be new ideas. Still can be discovery of new ways of figuring out how to do this because you have the population also with its own dynamics and maybe resistance that need to be addressed.
All right. We have a motion and a second on the floor. I believe each commissioner has now asked 3 questions. I've asked 4. All in favor?
Aye.
All opposed? Passes unanimously. Thank you.
Let me just acknowledge the tremendous support of the staff to make this possible, and thank you very much.
Yes. Thank you, Commissioner.
If I could just take a moment first to thank Dr. Thomas and the staff, and I'd also like to introduce Jackie Bailey, who's the owner of PD Health Home Hospice. Matthew Bailey, her husband, is the Chief Financial Officer of the Woody. And you may not recall, some of you may not have been on the commission, but what you've done is to just approve the first African-American owned hospice in Baltimore City history, having approved them to be the first African-American owned hospice provider in the state. When you approve them for Prince George's County, they are the only African-American home health agency in the entire state of Maryland. And so now that other hospices don't have the ability to be culturally competent in every way, but it was not specially mentioned, and nor should it have been. But after having voted, I thought you'd be interested in it.
Thank you. Thank you very much for sharing that
Thanks,
with us.
Andy Solberg and Jackie.
Congratulations and good luck. Agenda item number 4 is an action item on school-based telehealth work group recommendations. Nikki Majewski, Division Chief, Health Information Technology, will provide an overview of key findings from the school-based telehealth work group. In March 2018, the Senate Finance Committee requested that the MHCC convene a school-based telehealth work group to identify policies that advance diffusion of telehealth in schools. The recommendations are due to the Senate Finance Committee by November 2019. Ms. Majewski, please proceed.
Thank you. Good afternoon, Commissioners. My presentation today will focus on the recommendations proposed by the school-based telehealth work group. A summary of these recommendations were included in your meeting materials. So much of what Dr. Pollack just mentioned, we do have, we were tasked in March 2018 to assist policies in the state governing school-based telehealth in primary and secondary schools. The interim status report was submitted this past January, and a final report is due this November. In terms of the approach, we had about 70 participants and about 30 remain actively engaged over the last several months. And work group deliberations centered on benefits, barriers, challenges, and potential solutions pertaining to various technology and policy related matters, which guide development of these recommendations. There is a range of innovation that can be realized for school-based telehealth. Telehealth in a school setting can provide access to a wide spectrum of care such as primary care, chronic disease management, behavioral health, and speech therapy. The use of telehealth in a school setting has been found to help treat more complex conditions and keep chronically ill children in school. Many programs are still relatively new, and sustainability presents challenges as long-term funding isn't guaranteed. The benefit of telehealth in schools is its potential to improve both quality and academic outcomes. And it's viewed favorably in addressing about 90% of what is seen in general pediatric clinic. There has been many success stories, some in Maryland, that show how telehealth is enabling schools to address some of the most challenging problems related to access and provider shortages. Local initiative here in Howard County, through the hospital, the local health department, and several elementary schools are using telehealth as a way to get children urgent school-based health care. This program launched back in 2015 and has achieved promising results, many of which are noted on this slide here. In Arkansas, a telehealth kids asthma telemonitoring project has also helped 3 rural schools connect students to providers about 100 miles away, and this has reduced absenteeism, has fewer asthma symptom days, improved inhaler use, and has decreased asthma-related hospital admissions. Rochester, New York program as well has helped childcare and elementary schools that they have found that about 28% of visits in the pediatric emergency department could have been avoided through better primary care through telehealth. Of course, telehealth in a school comes with its challenges. Schools are taking different approaches as to telehealth, as they typically don't have financing or resources to take on the projects themselves, and many school budgets are mapped out years in advance. In terms of funding, it's a patchwork of Medicaid, private payer, self-pay, and grants. And then the school districts are also sometimes challenged in meeting requirements for federally mandated services, including these IEP requirements, which is the Individualized Education Program, and this might consist of finding qualified specialists such as a speech-language pathologist. The cost of technology tends to be lower, and the supporting costs such as staffing and finding space to accommodate a private telehealth encounter can also present some challenges. So here's just a quick snapshot of the current landscape in Maryland's 24 jurisdictions. There are about a little more than 1,400 schools. Telehealth is not used in school health services as there haven't been policies established, and Medicaid private payers do not reimburse. School-based health centers are also an optional way to expand access to preventative and primary care. These providers are located on site and which allows for reimbursement. There are 84 school-based health centers in 12 of the 24 Maryland jurisdictions. And in these 12 jurisdictions, that's about 600,000 students out of all combined 2.6 in the state. So about 5.3% of students in those 12 jurisdictions are enrolled in a school-based health center. At this time, I'll walk through the recommendations, which are intended to lay the groundwork for diffusing telehealth under the existing regulatory oversight framework within the Maryland State Department of Education and the Maryland Department of Health. This first one pertains to increasing awareness and involves leveraging telehealth champions such as parents, guardians, providers, school administrators to promote awareness and advance telehealth in schools through community partnerships. The next one pertains to privacy and security, and this is to rely on federal privacy laws as well as require students or schools to implement telehealth technology consistent with ATA technical standards. ATA is the American Telemedicine Association. Next category is policy development, and there's two subcategories. One of related to oversight, where the work group recommends leverage existing advisory groups established programmatic responsibilities to recommend policies for school-based telehealth. And then the second one under innovation would be to advance development of those policies to support innovative approaches and meaningful use of telehealth in schools. And the last one related to funding is to recommend that grant fund be established and be made available to schools that implement telehealth. I'll pause here for a moment if you have any questions about recommendations in the work.
Thank you. It's exciting, but I'm trying to get my hands around what would actually, if a school district thought this is a great thing to do, how do you even go about it in terms of what kind of students, what kind of disorders would be most amenable to telehealth, and then how do you set up the connections with the appropriate physicians? You know, just how do you go about it to begin with?
Well, each school has a variety of use cases that might work for them. Schools are often challenged with putting a nurse on.
Many schools don't have nurses, do they?
Yes, or they float, and so there are a variety of conditions. There's a lot of use cases around asthma, treating chronic conditions like that. But in Howard County, there's the diagnosis of strep virtually, and then that prescription is sent versus pulling the student out, waiting I think it's 12 hours to have the medicine kick in. So it ranges from, the small little diagnosis of something like that, even conjunctivitis, to maintaining more of those chronic illnesses like asthma.
So just to build on what Nikki has suggested, that's a great question. So it really starts with an application process. If a school is interested in one of the school districts, there is no cookie cut mold. It's a process. The school district would reach out to the Maryland State Department of Education. They would say, we're interested in establishing a school-based health center. There's a series of criteria they would have to meet. The Maryland Department of Education, Maryland State Department of Education would refer them to the Maryland Department of Health, who has a series of criteria. I believe it's roughly 25, that someone from MDH would go out and inspect the site, because it is a virtual clinic. But as a virtual clinic, it operates within a framework. So there still has to be requirements met around. You saw HIPAA, FERPA. And once the application process is approved, then it returns to a staffing point. A lot of times, school districts are outsourcing to find nurse practitioners. They are also contracting with provider groups, physicians to come in. Some use I think the one in Howard County is using the emergency department at the hospital. So it's a series of engagement, but it's a long journey. It costs nearly $580,000 roughly for a school to set up. Just the investment cost on a school-based health center. That's not the telehealth aspect, and then you can layer in technology and annual cost to maintain it. The funding approach today is more on reimbursements on the episodes, but there's an investment cost that really thwart the effort of expansion, if you will. And that's why so small numbers you see the 12 that exists in 12 jurisdictions as opposed to 85 that exist.
So what is the commission's role going forward? I mean, this sounds rather daunting.
It was
daunting.
So as a matter of opinion, the last 15 months of getting to the recommendations were a long, arduous journey, because there's shared oversight. There's lots of school districts with different ideas. And it's not easy to have a united front or a clear policy direction. You can have sort of, we're all headed west, but some people are going a little northwest and some people are going southwest. We, working with our executive director, talked about next steps. And as staff, we're thinking about, once the recommendations are submitted, bringing together an interagency group augmented by some stakeholders to try to advance the recommendations. We're not able to help on the funding aspect because it's crystal clear that's a challenge, but I don't think it's unique to just telehealth. I think it's all the challenges.
But I think just to remember that the Senate Finance requested that we convene a work group and put together a report and make some recommendations. Those recommendations go back to Senate Finance. Right. So what's the next step? It's our job to make some recommendations. It's Senate Finance's job to decide how to do it and how to pay for it. Well, they're going to want us to make a recommendation. Commissioner O'Connor's next.
The school-based health center, is it going to be kind of a replacement for the primary care of these children? Is the goal just to treat kids going to the nurse's office, or is it to take care of kids who have no access to primary care?
So a lead into your question. So on the established school-based health centers, one of the criteria around being approved under the MDH qualifiers is there's a continuity of care, that there is collaboration, coordination, and care delivery with the primary care provider, if you will, for that individual. These school-based health centers beyond telehealth see themselves as a way to augment primary care and not replace it in the community.
Commissioner.
I guess my question kind of is a subsidiary of that, if you will. I'm curious as to where the 12 jurisdictions are, and if there's anything within the grant funding requirements or recommendations to try to incentivize for underserved populations. I'm just curious.
So I can tell you the jurisdictions where they're at, and then I can answer the second part. Baltimore County, Harford County, Howard County, Baltimore City, Frederick County, Montgomery County, Prince George's County, Washington County, Caroline County, Talbot County, Dorchester, and Wycomico County are the ones with school-based health.
And the breakdown of that 84 is in the appendix of the slide deck.
But it is, so we should be thinking of that as 12 out of, what do we have, 22 counties in the state?
24 jurisdictions.
So about half the jurisdictions are doing it. And there's not to rain on parades, but it's not the notion that there's a critical mass of students in some counties and not in others. Therefore, like you say, if this is $500,000 or more just on the sunk cost to get it set up.
In one school.
In one school.
Correct.
So are they doing it only in schools where they're, I mean, is it that there's a demonstrated need? And like when you were asking about it, this is a big one for like little kids with type 1 diabetes, because the school nurse doesn't want to give a shot without, an MD going, yeah, give them the shot. So it's those kind of things. So are we getting the impression that this is poor schools can't afford it, or some schools have enough of a volume of kids who need these services that they've decided to spend the $600,000 in the school to set it up?
So it's a very complex answer, and I'm going to do my best to try to give you a succinct answer, if you will. It's driven by funding and available funding from the Maryland State Department of Education, because it's funded today through grants, and that's the only way this happens. And it's this application school districts say we're interested. It's typically not because of the level of care that's needed or the location. It's just the district says we're interested in doing this for all the right reasons. And then it's funding available from the Maryland State Department of Education, and then it's the application process.
Okay. So at least at this point, it's not kind of need-based.
That's correct.
My sense, and tell me if I'm wrong on reading this, was we're sort of where we often are with telehealth, that everybody agrees it's a great technology, we can try it out, but we don't really have any broad consensus on who should be doing it, when they should be doing it, how they should be doing it. So we make a bunch of recommendations that really are like, let's give some grants so people can do some stuff, and we're hoping that we'll gel at some point into a doctor in a practice going, oh yeah, I can use telehealth for these 5 things because that's what everybody else is doing it,
right,
into their practice. But we're not there yet with the schools either, because they all can think of things they might do, but there's not like 5 things that a school should be doing with telehealth that all the schools are like, yeah, we should all be doing that.
But there's also a public finance problem that we certainly have in this state and across the country of, if the state comes in and says, well, we'll pay for it, you go, of course. Why not?
They will, but that's pay for what?
But if the state's going to come in and pay for it, they're going to come in and pay for this versus air conditioning in the Baltimore County schools versus another need in another school. We're just looking at this in terms of its health value,
right?
But we're not looking at this from the standpoint of prioritizing it within the school's list of priorities.
Right.
So one of the issues here might be that we feel that this is an issue that really is different than other issues that school systems face, and probably shouldn't sit with the Department of Education in terms of how it's funded, as opposed to within the Department of Health. And as remembering again that our purpose is to make recommendations to Senate Finance, and we've been relatively silent on that issue here. Should this still be within this Department of Education, or should this move to the Department of Health?
Well, and do we have any I mean, I can see education say, well, we don't want to judge the health benefit. Do we see an obvious, through the process here, have we seen an obvious health benefit that this really works for these kind of kids in these sort of circumstances under these sorts of conditions? Again, long distances travel to primary care. Is there something that is really
a health benefit that they're going to get from it? Because if we say that it's an educational benefit, then it probably does belong in the Department of Education to prioritize the expenditure.
Right. Well, what I'm saying is if there's not a clear, I mean, I can see the education people saying, you health people should tell us whether this really works, where it's worth the money, that kind, and then we'll make the decision about air conditioning versus new buses versus whatever. But are we ready to tell our colleagues in the education policy that this works best when you have these kind of students and these kind of environments under these kind of situations? I'm not hearing that we do. Is there sort of I mean, education people don't want health people making education decisions.
That's right.
You know?
That's right. And is there a compelling, I guess the question
We
here
don't
is
have
there-
much standing, right?
Is there a compelling health benefit here that I'm missing thus far? You got close to it in the discussion around, no, not even ASPA, but the psychiatric and psychological services. So that those were services those students otherwise couldn't get, and they would become disruptive within the school environment. Maybe asthma as a
Management of chronic disease.
Is there a way in the final report to Senate Finance that we can talk about the compelling health benefits of these things in a meaningful way? Because if the strep throat thing, I'm sorry, I don't get.
No.
Take the kid out, send him to urgent care, he's going home anyway.
Right.
Do we have kids who are getting secondary consequences of strep throat because they're not getting treated? That's really not a Maryland problem right now. So we're solving a problem that doesn't exist there.
Commissioner Pollack, we can highlight this in the final report with the other points that are being made. The data for Maryland specifically is not very strong because it's not a lot of care, but we have enough national evidence that we can bring to light the very points that you're making.
I think that's where you justify the need for the money. If you're starting to see health outcomes, especially within the need for urgent, with emergency visits and people, if we're preventing people's asthma from being controlled, if we're keeping them from going into diabetic crisis because they're getting, those are the kind of arguments that I think just start to justify the investment. I agree with you. Strep throat, probably not going to justify a $500,000.
Conjunctivitis? I'm not sending that kid back in the classroom with conjunctivitis.
They're going home.
And the interesting thing, to just note one more time, is that the decisions on funding come from part of the budgets that are established for school districts under the Department of Education. And it's a tough call. Do you spend money on, as Dr. Pollack noted?
That's exactly why we need to understand the health impact of this. Because if it's about an educational impact, being able to keep the kids in school, that's really the Department of Education's determination as to how to prioritize
We have no
that.
expertise.
So how many of the Maryland counties are doing psychiatric services through telehealth?
So I believe it was like somewhere it's Baltimore City predominantly.
That's about 25 schools.
25 schools in Baltimore City.
Because that would be, if you're going to focus on something that keeps the kid in the school, trying to get an appointment for after school hours is extremely difficult for parents. But to be able to have a during the day appointment, and keeping the kid in school and just keeping the continuum, there's a lot of.
I think that's sort of the thing around the strep throat thing. I totally think with the schools being on the front lines, behavioral health stuff is very important, but sometimes they miss a whole day of school because of appointment and parents have to leave work. So it's getting that prescription sent over so it's in them and they can.
Or they don't get the behavioral health appointment, and then their ability to receive an education is impaired, and their degree to which they're disrupting the environment for others.
But it would be a very different structure if we were, if we look at the analogy of like school lunch, school breakfast. So if this was really health funds and we were saying we're going to use schools because we have access to that makes sense in terms of Medicaid planning and lots of different, how we would spend some. But if this is really education money, I do hesitate to to step out of our lane at all about an educational benefit here. We have standing on
Again,
health
these
benefits.
are recommendations to Senate Finance.
I'm
They
saying.
bridge across to others.
Right.
We can make that point.
But I think this limitation where we sort of say, for the health stuff.
Commissioner Gardner.
Just an observation, and admitted it's on limited time being here. It seems like we get a report a minute that we're asked to do from somebody. And this one being the Finance Committee. And our folks spend an enormous amount of time doing research and all these reports. And then we endorse it and we send it in. My fear is they turn it back and say, okay, now implement it. And then it comes back here again. I really question, and I think there needs to be some heavy emphasis here. I mean, having some familiarity with schools and things of this nature, I mean, and it's already been mentioned, many schools can't even afford to have a health nurse, okay? So we're not even doing the basics. And it worries me that our folks have to spend so much time doing reports on things that 10 years from now we'll probably still be sitting here talking about. So I would just hesitate. I don't know how we frame this, but, and I think it's nice to say these things, but it's just saying, yeah, we ought, it's a nice thing, we ought to do it. As long as it doesn't come back here, and certainly education, I can tell you, they're not going to do it either. I just question how we spend our time.
Well, this,
maybe
we're
we don't
we're
have any
spending our time
choice
the way
about it.
Senate Finance asked us to do
And
it.
we have to do it because they asked us.
That's the law, yeah, they passed a law, the governor signs it, we do it.
All right, so can we send it back and say, we did the report, but it's, go do something else because this isn't,
Yeah,
this ain't gonna fly for the next 20 years.
That can certainly be our recommendations, but they asked us to convene a work group. The work group made some recommendations. We can editorialize on those
The
recommendations.
motherhood
But that's what this discussion's about right now. If you feel like we shouldn't be doing this, this is a
I
bad
do.
idea.
Well,
We can
Our
editorialize.
staff wastes its time, and there's so many more critical things.
Well, whether or not we should be taking up this topic is not our call. That was assigned to us as part of it. But whether the topic is worth pursuing, that is something we're being asked. The Senate Finance did ask that it come here for us to convene the work group. Means we take the input and we provide an editorial response. So if that's what people think around the table, then we should include that in the editorial response. That's important.
I would recommend that you add a phrase that says, this really doesn't work without a healthcare professional in the nursing office at each institution that's going to have it. And until you require that appropriate staffing just to take care of the kids, don't even think about asking hospitals, I'm sure my stripes here, asking school systems to even consider this unless they're private and they can do anything they want. I mean, it's just frustrating to me to have folks waste so much time on these kind of things.
Commissioner Sargent was next. So Commissioner Sargent was next.
Oh, sorry. That's it. I'll be brief. So I think some of the discussion that I meant triggered this is I think these recommendations are fine for where they are now. But to me, looking at the different ones, policy development is what's really needed, right? We can sit and theorize, it could be this, it could be that, it could be this, it could be that. We're recommending that the people with responsibilities for the school's health center recommend policies. And the policy should say, we will use this for this service at this time and this, and then people can say, how much does it cost? Is it worth doing? Like, without that policy piece, I don't know that the ball will ever advance. And we're not here to decide what the policy is, but I think maybe our report should emphasize that is really the next step before you evaluate whether this is worthwhile or not.
Commissioner Thomas.
I would think the CHIP's larger question would simply say that this body has garnered a tremendous amount of credibility. And from reports from infant mortality to hospice, all these little things in between, because there's a tremendous amount of confidence that the reports, staffing is professional, objective, impartial. Around two tables like this, I think that they like that. Now, it could result in what you're describing, and hopefully these mandates come with resources. That helps. It's the unfunded mandates that become more difficult. I think it's also a sign of the kind of respect that this commission has garnered over time.
Commissioner Boyle.
I'd like to just follow up on what Commissioner Sargent indicated that what was missing here, I was kind of glazing over, it all sounds good, but spelling out the, what has to be determined are, policy issues or what type of disorders, how would it work, be more specific on what's missing.
Just following, and again, jumping on to all of this. So I believe we should express not only what Commissioner Boyle said, but in addition to that, that policy should first be created and who it should be produced by. Do we feel that it should be produced by a healthcare point of view, or should it be produced by the educational point of view? I think it would be something of value and will point direction to the General Assembly on how to move forward. So I leave that up to debate between us.
I would say that what I like about the recommendation is that the policies are coming from advisory groups that are currently responsible for the school health centers. So it kind of is it health, is it education? They're doing both in a way. Like we don't have to recommend on education policy as much as the recommendation here is for the policy development from those schools.
All right, last comment.
All right. I think what's more important here is behavioral health. I think kids who are disruptive in class, I think, is an impediment to the rest of the kids learning anything. I think teachers are too tolerant of that. It should be a place where the kid is told, the old days, go to the principal's office. They don't do that anymore. They tolerate these kids, they're disruptive. I think behavioral health, as opposed to sore throat and like conjunctivitis, especially in light of what goes on in the world now. I think behavioral health would find funding in schools, and that's where it should start.
So you've heard a variety of comments from commissioners regarding our thoughts on this issue. I think it's probably, rather than improving the recommendations that are in now, maybe updating the comments to reflect the fact that there's a diversity of opinion amongst the group with regard to the prioritization of this, that the question of whether the funding for this and the regulation of this should sit within the Department of Health, the Department of Education, should probably be based on the nature of the program and its goals. If the goals are to keep the children in school or to control the school environment, that's a Department of Education issue. And if the goal is a public health one, then that's a Department of Health issue. And using that, we've heard around the table here, add the editorial component to the work group's comments, will get us to the level of approvability.
And staff will be sure to add this.
Thank you.
So to be clear, we'll bring this back next month. Or would we be best, in your opinion, David, to wait until November?
Just to level set, the recommendation is due by November 1st. So
We have to come back next month. Right, we don't have a version that we can approve right now.
Nikki does not expect these fireworks.
No, this is great.
And again, it's a healthy discussion, I think, and it's not that this is I think this is a reflection on the fact that Nikki presented this in a way that was allowed us to consider it very carefully. So, great work. Agenda item number 5, action. Hopefully less controversial, straightforward, folks. No credit for asking questions. No demerits either. Appointments to the MHCC Cardiac Services Advisory Committee. The Cardiac Services Advisory Committee is a standing committee of the Commission established in 2015 to advise the Commission on regulatory and related policies affecting cardiac surgery and percutaneous coronary intervention services, otherwise known as PCI. The committee includes representatives of the Maryland chapter of the American College of Cardiology, the Society of Thoracic Surgeons, the Maryland Institute for Emergency Medical Services Systems, and independent hospitals and health systems. It also includes a member who can provide a consumer's perspective. Currently, there are 2 openings on this committee. Eileen Fleck, the Chief for Acute Care Policy and Planning, will provide the Commission with nominees for these open positions and request their appointment to the committee. Ms. Fleck, please proceed.
Thank you. Good afternoon, Mr. Chair and Commissioners. So Lisa Myers from MIMS, she resigned from MIMS, and the nominee to replace her is Heather Green, who's the Director of Cardiac. Oh, I'm sorry. And nominee to replace Lisa Myers is Anna Acock, and she is the Chief for Health Facilities and Special Programs with MIMS. I've given you a copy of her biography. She has a Master's in Healthcare Administration and a Bachelor's of Science in Nursing. And she's been also a director of the stroke program at MIMS. If you have any questions about her, I'd be happy to answer them.
Heather Green.
Lisa, I'm sorry, I was referring to
No, no.
Ms.
Go ahead.
Oh, go ahead with the next one. Okay. So the next nominee is Heather Green, and she's going to replace Jim Ridge, who was the executive director for cardiovascular diagnostic imaging. Heather Green's position is director of cardiac services. She's also been a manager of the cath lab at Carroll Hospital. She's been with that hospital for about a dozen years. And I've also given you her resume. If you have any questions, I'd be happy to answer them.
Do we have any questions from commissioners with regard to the two resumes that have been presented to us somewhere in our packets? Hearing none, do I have a motion to approve the two nominees? Second? Any questions? Hearing none, all in favor? Aye. All opposed? Motion passes. Congratulations.
Thank you.
Agenda item number 6, privately insured spending in Maryland's individual market, early update 2018. The Maryland Healthcare Commission is required under a legislative mandate to report annually on expenditures for privately insured services using the Maryland Medical Care Database, the MCDB. Healthcare Commission staff have made assembling the MCDB data on a more timely schedule a priority for the contractor. They will have a presentation on healthcare spending among Maryland's privately insured under 65 population that purchases insurance in the individual market. This market includes individuals that purchase ACA compliant products on Maryland's health insurance exchange, those that purchase ACA compliant products off the exchange, and those ACA compliant products, and those that purchase grandfathered plans that existed prior to the ACA. Like your health insurance, you can keep. These results reflect utilization in the individual market through calendar 2018. I also want to note that in 2019, Maryland launched a reinsurance program to the individual market that stabilized premiums and increased enrollment. Commissioners will look forward to seeing those results on an even more accelerated basis in 2020. Kenneth Yates Trotman, Director, Center for Analysis and Information Systems, will give us an early update.
Thank you very much, Chair. Commissioners. As Commissioner Pollard said, this is an early update of the 2018 spending focusing on the individual market. The reason why it's an early update is that the information in the MCDB, we're still going to do some quality checks with payers. So, but we wanted to roll this out as we think that the data is usable and this probably would be useful, to have an early view of spending, in 2018. This report on a wider view, which we will look at all markets, will be released in early spring. So it's about 6 months ahead of time. So as we noted that MSCC is required to report annually on healthcare spending and utilization. The information here is from the medical care database, and those that database includes data that has been submitted by health insurance carriers, third-party administrators, pharmacy benefit managers, and the data here is from 2015 through 2018. The population here is Maryland residents who are under age 65 and enrolled in privately insured plans. As we said, the focus here is on the individual market. Look at this slide. This slide shows enrollment end of the year for each year, 2015 through 2018. As on the blue bar, you can see that enrollment continued to decline in 2018, decreasing by about 15% in 2018 after about a 9% decrease in 2017. As said earlier, the launch of the reinsurance program by ACA 1332 waiver, which resulted in reduction of premiums, which is a win for individuals that are enrolled in this market, should halt the downward trend of this market, decreasing enrollment in 2019. So we look forward for those results in 2019. The expected enrollment increase due to the waiver is an estimate of about 5.8% increase in enrollment. So, but we'll see maybe a little less than that is probably. Looking at the morbidity level of this market, we see that there has been a stable of the risk score. The Medicare, the median expected risk score has remained stable from 2017 to 2018. And this is an indication, as one could suggest, that there has been a reduction of people, healthy people leaving the market. So therefore, there is not much change from 2017 to 2018.
Does this include Kaiser for all years, or?
This includes Kaiser from 2015 to 2016. Yes, okay, that's correct. And Kaiser, I must say, note that Kaiser is only included in the member population for this presentation. As we have
it's not included in the expenditure.
We have those prices.
Just one question. In terms of the risk scores you're giving here, you're giving median risk score. So is this a particularly, I mean, a 0.20 seems very low to me. I'm used to them being standardized at like the average beneficiary is 1.00. Is this like a lot of kids, or am I interpreting this wrong?
Well, a 0.20, I remember, a 0.20 is where we have the full majority of the ACA population. You know, we also had the MHIP that came on from that high risk pool. So in 2015, you'll see a lot of people in the 2015 population will have a lot of health challenges. So therefore, it's not surprising that you'll see a 0.20. However, as we move forward,
Is that, should I, yeah, I just want to clarify. So when I see the 0.20, am I thinking this is a person that the average is 20% higher than the average person in the state? Or that they're 1/5 of the average person in the state?
This is a metric unto itself. It's so this isn't standardized on say 1 or 0, as far as I know, Ken.
No,
By comparison, the overall uninsured market is about what? The score for the privately insured market overall is what?
It's about 0.3.
Okay.
All this tells you is the trend in the risk score in the population.
Yeah, if I was an actuary, I'd call this adverse selection.
That's correct, yes.
So, I mean,
That's the point, that's the point being made.
How nervous should I get?
With the correction for it's already been.
Okay.
This is all
Less
pre,
nervous. Less nervous, okay.
Less nervous.
Good.
The reinsurance is in place.
The steps have already been taken. Got it. Thank you.
So as you can see, that population have stable in 2017 going to 2018. Looking at spending, this exhibit shows PAPM spending as an overall and also by service category. Looking at the overall spending, we see a slowdown in the increase in spending in 2018 at $579 from $537, and that is about an 8% increase from 2017. 2017 had about a 16% increase in spending. So we can see that there's a slowdown in the spending as far as this market is concerned. Now there are 3 service categories that have contributed to this slowdown. So the inpatient hospital facility showed about an 8% decrease in 2018 at $77, and at $84 in 2017. That was about a 14% increase from the prior year. Looking at the professional services at $156, we see that is about a 7% increase compared to about an 80% increase in 2017 at $146. And last but not least, the prescription drug we see at $186. That is about a 21% increase from 2017. And from 2017 at $154, that was about a 33% increase from the prior year. So we can see a slowdown in these 3 service categories. These 3 service categories have contributed to over 70% of the total spending in 2018.
But Ken, you're saying that the prescription drugs actually accelerated, correct?
No, the increase is less.
Okay, okay, you're talking about the percentage.
Yes, but that increase is less in 2018 than in 2017. Moving on to the drivers that caused these changes from 2017 to 2018. Overall takeaway from the slide is that utilization has shown either no increase or no change as depicted in the inpatient and outpatient hospital, or have decreased in every service category except the prescription drug, which had about an 18% increase in utilization. And that was the primary driver of that 21% increase in the PMPM spending for prescription drug in 2018. Taking a closer look at prescription drug spending, this exhibit shows PMPM spending for generic versus brand. And we see that 21% increase was driven by the brand name drugs, which at $147 in 2018, that was about a 21% increase from the prior year. We see that generic did not show a lesser contribution of the 21%. Also, the unclassified display we see on the right, we include that for completeness, because the generic plus brand would not exactly add up to the total. So generic plus brand plus the unclassified will show the total PMPM for 2018 or prior year.
Did you?
Yeah, that's a good question.
Yes.
Question?
Thank you. When you're talking about brand, do you have this broken down to what type of prescriptions you're talking about? I mean, are most of them biologics, for instance, where there are no?
We do, but we didn't have a chance of providing that information, in this early view. But in the spring, we will have that detailed breakdown of the kind of drugs that contributed to these changes. So that will give a more narrow detail as to what type of drugs that contribute to the increases or changes from 1 year to the next. Looking at the utilization for brand versus generic, the 18% increase in utilization was primarily due to generic name drugs. That had about a 16% increase at $591 from the prior year. Brand name drugs, as you can see, much lower utilization. That is not a surprise. That only had a small increase of about 5%.
Ken, any idea why? I'm sorry.
Go ahead.
Any idea why, if we didn't see much of a difference in the risk score, especially in those last 2 years, kind of rounding error there in those, that we still see this? I mean, are these folks just suddenly taking a lot more drugs? Did something change in the benefit design, or something that suddenly made kind of the prescriptions drugs? I mean, these look like big. I mean, the generic is luckily it seems mostly to be generic, not brand. But overall, the area, their utilization seems to have gone up significantly in between 2 years where the risk score didn't seem to differ much.
Well, bear in mind that that we have a lot of chronic folks in the market. So although the risk score did not change, but these people have to treat their chronic illness.
Right.
So of course you see that uptick in the utilization.
So you think that we have a different mix of chronic versus acute? So the risk score doesn't move much, but we're now paying for insulins and other things like that.
The risk score doesn't move much because it seems that population a lot of people, a lot of health people have left that population. So now we have sick people in the individual.
Absolutely, the adverse
so
selection.
Therefore,
right.
Although the risk score have not changed that much, when you look at the risk score is at 3.34, still a morbidity problem. So with that, these people still have to actually use their prescriptions to take care of them.
Yes, it just looks to me like they use more, even though it doesn't look like we have any, in the last 2 years only. It doesn't look like we have a particularly sicker population, but we certainly have much more drug utilization.
It seems like an adverse selection problem that's incompletely explained by the risk score. The risk score is not adequate to explain the change.
It could, certainly, it could be, more poorly managed diabetics, or, something that just is not going to be.
They're better managed now
Because they're taking all their drugs. Right. Now they have coverage, now they can get to it, right?
One thing.
Well, at least they're buying all the drugs, whether they're taking them is a different question.
And one thing to look at is, if you look at the cost increase, it's all brand, it's the same. 2,000 scripts per 1,000 PMPM utilization. It went from $78 to $147 PMPM, whereas the brand only went up by about $10 PMPM. Even with all those additional scripts, the cost per member per month is $10 more for that period of time. So as opposed to more than doubling on the brand side. So if you're looking at amount of drugs taken, if the generics way up and the risk score is a little better, you might find that there's two completely different stories going on there. One about costs and one about like relatively expensive drugs that might be helping out.
Right.
Sure. Yes. The state of Maryland, I don't know if you know the federal, the state of Maryland negotiated with drug companies all the time.
Independent of the federal government?
Yes.
Not
Independent
my
of the federal.
So for the Medicaid, this is only privately
This is
insured.
privately insured, so the answer would be no.
Okay. Carriers negotiated by the states.
Right. Medicaid insurance statement could be.
So from a cost per strip standpoint, well, nothing much to see here. As we see on several slides back, we see that the increase in prescription drug spending was primarily due to that 8% increase in utilization and about the 3% increase in cost. So this here says that the unit cost here is mostly driven by the brand name drugs. And lastly, we take a quick look at the on exchange versus off exchange spending for all services combined, premium spending. So we see that that over the years from 2015 to 2016, we see that they have been a small increase for the on exchange, about a 6.5% increase, and then it jumped up to about 25% increase in 2017. But going from 2017 to 2018, there has not been much increase at all. But in fact, there's kind of a slowdown in the spending. So that only increased about 2%. Looking at the off-exchange spending, kind of a similar pattern, but much more drastic. In that we see a increase to 2017, and then a decrease, of about 8% in 2018. Which 2017 had about a 9% increase.
Ken, is the off exchange, what does that include?
The off exchange, these are just ACA compliant products.
Doesn't include the grandfather.
No grandfather, no. These are just ACA compliant plans only.
So to the question that Commissioner O'Grady asked, there might also be some substitution of drugs for some medical services. It's hard to tell here, but the things of overall spending between 17 and 18 is kind of unexciting or less worrisome than the pace of increase in drug spending. We can't prove that, but it does seem as though that could be a problem. The other thing about ACA products in Maryland, given the way we approved the benchmark plan, it wouldn't inherently mean there would be more drug spending. But there's, in terms of the formulary on the benchmark plan, Maryland has a very benchmark plan that has many more drugs included in it than most states. I think from the low 650 drugs in the benchmark plan in one state to I think the next highest in Maryland is about 1,025. I think we're at 1,075 drugs. So over time, that should kind of adjust itself, but we have a lot more drugs relative to what other states have in their benchmark individual market plan.
With this, dangerous exchange chart says to me that the subsidized population is sicker than the non-subsidized population because all the people off exchange are not subsidized, and the people on exchange are mostly subsidized. With then anybody that wants to can combine with the exchange.
Yep.
But you say there's a reinsurance program that is coming in to help.
In 2019, came in, and
it to reinsure the premiums, or is it sort of a loss on for the insurer?
It's an attachment point of $20,000 to $270,000. The state pays 80% of the charges in that window, and it applies to both on and off exchange ACA compliant products. So it's a pretty big fight out of premiums. Premiums drop 15 or 16% on average between 18 and 19.
Okay. Do we have any responsibility for keeping an eye on that?
Well, the primary responsibility is with the health benefit exchange, but we're talking about greater collaboration with the insuring authority because they largely get enrollment information, whereas we have a rich source for utilization.
I only bring it up because I know the feds have struggled with this. Their reinsurance costs tend to be going through the roof when it's not really reflected in premiums. As a matter of fact, it's kind of kept down. But certainly as a budgetary matter, it's becoming it's just growing at a faster rate than the rest of their program.
Okay, so what are the takeaways? We see from the first slide that enrollment in this market have continued to decline. I'm showing about a 15% decrease in 2018 after about a 9% decrease in the year prior. But however, we are hoping that this downward trend will stop by the effect of the insurance waiver. We saw also that the morbidity level in this market have stabilized in 2018 as shown from the median risk score, and that suggests that healthy people that exist in this market previously have actually slowed down in 2018. Also, we see that the overall spending in the individual market was about 8% from 2017 to 2018, and that was primarily driven by prescription drugs. And for prescription drugs, we see a 21% increase, which lead all service categories, and that 21% increase was primarily due by the utilization of 18%. Lastly, we just saw from the previous slide that there's a slowdown in spending on the on exchange as well as off exchange, but more drastic in the off exchange, where we saw a decrease about 8%, from the previous year, which had about a 9% increase in 2017.
Other questions, commissioners? I know people have had a chance to ask throughout the presentation.
Is there any way of measuring the churn in this market? Like how long people are staying in their plans?
We could actually we could take a step at that and have that for the next.
Maybe for next year or something. How many people are going back and forth to Medicaid? How many people are keeping their policies? It's a very volatile market. It's hard for management programs like care management to actually fight if somebody's only going to have a policy for 3, 4, 5 months.
Sure.
Thank you.
to add on to the reinsurance program, pumped about $400 million plus dollars into the individual market in 2019 on a total budget of about $1.2 billion. So it's got to have a big impact on premiums. I think the question is, in 2019, will we see that? What happened to utilization? Theoretically, that may not have changed too much because the funders just changed from the insurers to the state of Maryland. I'm sure we may have done too much on it. Any improvements on utilization?
Well, if you have a less sick population, if your risk score comes down because now it's affordable,
that too.
You can certainly have that.
That's right.
Thank you. Agenda item number 7, the quality report for the consumer website. As you know, the Commission maintains the Maryland Healthcare Quality Report's consumer website in fulfillment of our mandate to increase transparency and informed decision-making among consumers and to facilitate improvements in the delivery of care in Maryland. Teresa Lee, Director of the Center for Quality Management and Reporting, will provide an update on efforts to improve and expand upon our website and the supporting infrastructure.
Thank you, Chairman Collins. Good afternoon. Also with me today is Brian Dorsey. He is the Director for Business Development at National Government Services, also known as AGS. He's here today because we've just completed a very long and complex procurement, and AGS is the winner of that contract that will again support the website and the infrastructure associated with the consumer site. Let's see. I will try and be brief. Just a review of our staff presentation outline. What I want to do is give some background on where we have come from with respect to this project. Originally, our quality reporting comes from 4 legislative mandates that go back as far as 1999 for nursing homes, 1997 for health plans, and then 2002 for hospitals. So we've been doing this for quite a long time. And in 2009, the Commission made a commitment to invest in the infrastructure to expand upon the hospital reporting by establishing a parallel processing system, parallel to what CMS was requiring, because at the time it was difficult to get data from CMS. We can download it now, but at the time we could not. And it was also a time where patient experience measures were coming into play. So we wanted to have access to that. And we did this in collaboration with HSCRC because they were just starting the quality-based reimbursement program, which is part of the Maryland model, and I believe it's called Total Cost of Care. And then following that 5-year period, between 2013 and 2019, we entered into another contract, and through that contract, we consolidated all those individual mandates into one website, which is what we have now. And then going forward with our contractor, AGS, again, we plan to redesign the website and the supporting infrastructure. This is just our overall mandate. So the 5-year period I mentioned between 2009 and 2013, where we first developed that infrastructure, which we call the Quality Measures Data Center, it actually was the portal through which hospitals submitted all of their quality metrics and HCAHPS scores. And then that allowed, as I said, for us to have more current reporting on our website and for HSCRC to implement the quality-based reimbursement program. There are other developments that happened during that time. I won't go through each of these because you have a copy of this in your slides. The second 2013 to 19 most recent contractual period, which we had AGS as our contractor, we repurposed that QMDC to use the front-facing part of that to be the quality reports website, and then the portal where hospitals usually submitted data. We just now use it for cardiac data and also a source for hospitals and other providers to get information about requirements, et cetera. Throughout the process, we've engaged consumers. We continue to do so. We also at the time established a price transparency feature. Prior to that, HSCRC would provide us a PDF document of the top 14 APR DRGs with the price, length of stay, and volume, and that's what we posted. During this period, we converted that PDF, took over that function, and now we have consumers can actually look at prices for all types of APR DRGs as the categorization is, but you can actually search much better. So moving forward under this, the new contract that actually was approved by the board 2 weeks ago, we are going to focus on establishing an outpatient data collection and reporting system, as well as an outpatient guide. Really have a very limited display on the website now, so we, as we put into our annual report, this is a priority for the commission. The long-term care guide, which is widely used, I think, by consumers when they're searching for nursing homes and other services for elderly family members. We plan to also redesign and integrate fully that long-term care guide, which was previously done by another contractor. So what we're hoping to do to this major redesign is to have consistency and continuity across all the guides on this website. Let's see. And we continue to try to promote as much as we can the website. We've done fairs, we were in the advertising in movie theaters, we do social media posts. There are a number of things that we have done, and we have some ideas on how we can work with the department during this period of when they're focusing on diabetes as a major public health effort, to see if somehow we can collaborate with them. We can be a website that helps to push this, to promote it, just to try to see if there are other ways in which we can promote the website and also capitalize on other activities and other state resources. The objectives of the procurement, kind of gone over that. Our focus will be the ambulatory surgery guide as well as the long-term care guide. Validation and clinical data auditing has always been a major component of these contracts. We'll continue to do that, particularly with outpatient data and other data sets that are new to our use. And we also have incorporated an analytic component so we can begin to utilize the data more creatively. For example, patient experience data. One can look and break it down by type of patients, surgery patients, maternity patients. And I believe you can now break it down by race and ethnicity. We want to look into doing some of that. So we built in the expertise and funding and resources within this new contract to do a little bit more, be a little more creative with the data that we have. That is my summary of where we are. So if you have any questions, let me know. If not, we do plan on coming back on a quarterly basis if we can, just to keep everyone up to date on what we're doing as we go forward.
Commissioner Thomas.
Very quickly, excellent report. I'm looking forward to your design. In terms of promotion, I've been at one of these missions of mercy, but I would highly recommend there's 4 across the state. I mean, thousands of volunteers. This is the audience that needs to hear this. They need to know about quality. They need to know. And at our event, we had the Maryland State Insurance Consumer Agency. They really like being able to touch this audience. And then the last thing has to do with your long-term care guide. I don't know if we have any other guides, but given our previous conversation, you know, a hospice guide in terms of the context we were discussing could be quite useful.
We do have information on hospice services. We have a quick compare for home health, just a way in which a consumer can just go and look at some information very easily. Our long-term care guide is comprehensive. It has lots of information, but it's a lot of information to navigate through. So under this redesigned activity, we really want to keep it simple to the extent we can. We don't have to report everything just because it's available and there, but we really focus on what people are most interested in and then build from that. But thank you so much for that suggestion to tap into what you're doing.
Yes.
Oh, is the redesign going to be focused mostly on the mobile? I mean, I get a very different experience when I go to my desktop versus my phone and trying to understand the site.
That is absolutely a component of what will be brought to the next contract. Actually, the president of the company was scheduled to come here to talk a little bit more about the kind of expertise and services that will be incorporated in the next contract. But unfortunately, she had death in the family, so she wasn't able to make it. So I don't know how much time.
Sure, I can explain a little bit of that. So the new design is going to be based on a cloud-based infrastructure, which allows us to take advantage of what are called APIs, which are application program interfaces, which allows you to design a website that allows you to take advantage of the stuff that's in your phone, that's in your tablet, that's in your particular type of computer, which allows it to personalize that website as you view it. So what used to be a hard-coded thing on a website, which is you hard-code something for mobile, you hard-code something for desktop, using APIs and Web 2.0 technology, that will be automatically put into this. But that also will let us take advantage of other things that I've heard of today in the commission. Search engine optimization, which is to how to drive more eyes to the site, how to make the site more user-friendly. If you go the second time, it's more personalized to the last time you used it. All of those things in conjunction with what the commission would like to do will be available during this contract.
And just a follow-up, you know, again, I've said before, it's great information to have there. But sometimes when I first went to the site, it was very difficult to use, very difficult to understand what's really there. Are you going to be bringing, we're having focus groups, or you're bringing people in to insist on making this consumer friendly? You're going to have people from the outside who've never gone there before, who is one thing when you're working here and you know all about it. It's another thing when you're just new to the site. You know, what is this? How do I find it? What does it all mean?
Yeah, we do have a separate contract to sponsor or run consumer focus groups. We've held them throughout the development of even the current website. And it's important to know that the current website is based upon free software from ARC. The federal government provided that. So the contractor was able to rebuild and reestablish a website that consolidated all of those different sites, but it still has limitations. And it's now 5 years old. So yes, the answer is there'll be quite a few new features in to make the experience more user-friendly, mobile ready, I guess that's the term.
We also will develop the site using an agile approach, which will allow us to take advantage of that stakeholder input on an ongoing basis and make quicker changes as stakeholders provide that input to the commission.
Exciting. And if I could say, well, do you have a question?
I do, but I just noticed that the state health department has started using kind of new media much more. Like if you ever listen to Pandora on your radio, you know, you hear them all the time. Mostly their opioid kind of outreach and things like that. And I just didn't know whether we had any plans to sort of move into those sorts of.
We've done that.
Okay.
Yeah, we were on the radio. We were in the movie theater. So, and that's why I think it would be good to have an inventory of what we've done, so that we can get additional ideas for new things to be done. And what I wanted to add before I forget is price transparency is a big piece of our discussion and what we do. We do have by DRG volume, average price, and length of stay. And now that CMS requires hospitals to post that, we're hoping we can work with the hospitals collaboratively to come up with a standardized format in some way so that consumers can see the same thing wherever they go. I think that would be helpful. I don't know how successful we'll be, but we just wanted you to know that we're reaching out to the MHA and to other entities to see if we can collaborate on
Great.
Thank you. Thank you very much. Agenda item number 8, study of mortality rates of African-American infants and infants in rural areas. Megan Redford, Chief of Government Affairs and Special Projects, and Dr. Sandra Quinn, Professor and Chair of the Department of Family Science at the School of Public Health at College Park will present on the 2-year study on infant mortality in African American infants and infants in rural areas. The study is a result of a legislative mandate. This presentation is meant to provide an overview of the project and a preliminary discussion of the draft report. MHCC staff plan to present a final report to the commission next month. Megan, Dr. Quinn.
So good afternoon. As the chair noted, we've been working on this study since 2018. This is just a preview. You will not be asked to vote today, but the material is fairly complex. The report is fairly complex, and so I wanted to give everyone a chance to see it and give feedback before we have to come back for a vote. I am joined today by Professor Sandra Quinn from the University of Maryland School of Public Health. She runs a team that has been very helpful to us, supporting us in research and project management. So just to give you a sense of what we're going to talk about today, we're going to talk about the legislative mandate for this report, the process we've used in conducting the study, and then go over some of the data and findings, and then review the recommendations. I've left time for discussion at the end. Time is relative because we're already at 3:20, but please feel free to interrupt throughout if you have questions. So in 2018, the legislature required us to conduct a study on mortality rates in African American infants and infants in rural areas in Maryland. Those are two separate but overlapping populations. The study had 6 elements that we were required to meet: an examination of factors related to infant mortality, research of programs that are best practices, methods to, and then we were required to make recommendations related to methods to reduce the infant mortality rate, the use of community health workers, and recommendations related to the establishment of a permanent council on disparities in infant mortality. And then finally, recommendations related to methods to reduce costs. We've conducted this study in collaboration with other state agencies. MHCC is not the lead agency doing the operational work on infant mortality. That work all happens through the department, and there are a number of components of the department that do that work. So we've worked closely with Medicaid, with the Bureau of Maternal and Child Health, and the Office of Minority Health and Disparities, as well as the Office of Vital Statistics. We also entered into an interagency agreement with the School of Public Health to help us with research for the study, as well as project management and writing the report. And then finally, we have a stakeholder work group. This has been a pretty robust work group. We've had 7 meetings at this point. We'll have 8 by the time we're done. And we've had more than 60 participants from a wide range of professional organizations, advocates, and institutions and insurers. And just to give you a sense of timing, as I already mentioned, this is just an initial presentation. We'll make revisions based on your feedback and based on a work group meeting that will be held in early October, and then we'll come back to you with what is hopefully a final draft in October. The goal is to submit by November 1. So then turning to the data and the findings, Maryland has more than 71,000 births annually. The births reflect the increasing diversity of our state. 57% of births were either non-white or Hispanic. We also had 462 infant deaths in 2017. I think it's useful to put numbers in context. That's about the size of my elementary school. I did grow up in a small town, but that's a lot of children that we're losing on an annual basis. And the leading causes of death are low birth weight, congenital abnormalities, and SIDS. looking at the 5-year period between 2013 and 2017, the infant mortality rate for Black non-Hispanic infants is 2.5 times that for white non-Hispanic infants. The mortality rates for African American infants improved between 2008 and 2012, but the rates for Hispanics worsened. And I have a graph in the chart in the deck that'll show that more clearly. So here's the visualization of that data. It allows you to see it over the 10-year period from 2008 to 2017. Infant mortality rates by race and ethnicity. The blue line is white non-Hispanic. The red line is Black non-Hispanic, and the green line is Hispanic. So you can see those trends and the significant disparity between white and Black infants. We were also asked to look at rural infants, and that was partly because the trend you see in this graph. So while infant mortality rates for infants in urban areas have historically been higher than those for infants in rural areas, they are trending downward or at least flat, whereas the trend for rural areas seems to be going upwards, and that's concerning, and so something that the legislature wanted us to pay attention to.
I'm sorry. Are we wedded to the county's analysis?
So yes and no. So in Maryland law, the idea of rural is defined by county. And so you'll see that that's how I define rural for this purpose. We did have an epidemiologist who has left the state. But if you look in the appendix A2, which I know is deep into the report, you may not have gone that far. He did do some look into smaller than county level geography. The problem is that infant mortality is relatively rare. So when you start splitting up the data by smaller and smaller units, you have to add more time. Use a larger time span to make it statistically relevant, at which point you start losing time trends. So it's a trade-off between approaches.
Right. It just struck me, like, I'm from Howard County, and it's not usually what one thinks of as urban. I mean, there are urban portions, but it feels like the suburbs are lurking in here in both categories and probably have lower mortality rates than either truly rural or truly urban that we think of. So it may be skewing your results.
And when you say it's sort of set, do you mean like Census Bureau set, or the legislature asked for particular counties to be considered urban?
No. In Maryland law, there is a definition of rural, and it is defined by county. The specific piece of legislation that directed us to do this didn't specify that we use the state definition, but it's an easy default. And it's also a large enough geographic area that we don't run into the long time period problems.
So by comparison, you use the Department of Agriculture's definitions of rural, you would end up with 2 rural counties in Maryland, Kent County and Garrett County. So we have a more generous definition of rural, which is probably okay. We're focusing on issues related to specifically, but obviously you get cohoffs when you talk about Maryland as a rural state if you're dealing with our colleagues in Montana.
Mr. Thomas.
Just very quickly, new tools have come online that would allow you to look at this as you have, but then to look at it within the context of what they are calling neighborhood deprivation index. So as long as you have that information, you can literally say whether rural or doesn't matter, what is the deprivation index? And that's what's driving potentially some of this. So it's just it's another overlay. All the work's been done. It's simply using it as a tool through which you look at this information. And that will deal with this outlier effect.
Thank you. So this graph I'm showing now overlays the race and rural and urban. And there you can see that there's a particularly important trend that we should pay attention to with respect to African American infants in rural areas. And you can see that where the statistically significant difference circle is, you can see that that's the difference between African American infants in rural areas and urban areas. And geography does not seem to matter that much for infants, for white infants, at the bottom of the chart. Okay. So in addition to sort of big picture data like I was just showing you, we also did some analysis using vital statistics data on specific factors related to infant mortality. We were limited by the factors that we could easily identify in vital statistics data, so that's certainly not everything we would have wanted to study. But we looked at factors related to educational attainment, smoking, marital status, insurance source, prenatal care, and some factors related to the health of the mother, including things like gestational diabetes and hypertension. There were a couple of factors that jumped out as being particularly important, and I wanted to show those two to you today. So this one is breastfeeding that occurs in the hospital before discharge at birth. It just seems to make a very stark, be associated with a very stark difference in outcomes. Yes?
What kind of regression modeling can be done to determine this is an independent predictor as opposed to a marker for something else?
We haven't, so we don't
Dangerous,
have yes.
Dangerous piece of information.
What an amazing question from an MD.
Took epidemiology.
I'm very proud of you.
Public health.
I mean, the conclusion that the public would draw from this is that you have to breastfeed in the hospital once in order to protect yourself from infant mortality, and that is not what you're able to show here.
Yeah, and yes.
I think your point's well taken. I think what we also know from the literature is that breastfeeding is associated with a reduction in infant mortality. What is critical is, the issue of when we can measure it is at discharge.
Sure.
And that is, one of, I think, the limitations of what we have here. Later on in the recommendations, you will see recommendations related to assessing breastfeeding at follow-up postpartum visits as well as at pediatric visits so that we can get a better sense of what happens, because it's complex, doesn't always work early on, and it takes real effort. So your point's well taken, and it really suggests the need for further education for all providers as well as the public about this.
Yeah.
Well, it also suggests the need for an additional analysis. I mean, I do believe that breastfeeding will probably still be a significant variable, but I'd like to know, is it a 2% or is it a 20%? And what is that relative contribution in the most rigorous way we can measure it? And it sounds like you have, the other variables, to kind of really specify this out a little bit better. So if you could come back to us and give us our, the R squared, how much of the variation are you really explaining by the month? And what is the independent effect here? That would certainly allow us to avoid the trap that, is repeated often, where you have a correlation.
Yeah.
But the multilinearity that's going on here is really, you're really picking up a lot of different things going on.
There are also a variety of other psychosocial factors that we're not measuring.
Absolutely.
That may be associated with breastfeeding, right?
And I guess one question I had looking at this, because since we're only talking about breastfeeding like once before you go and start, are the infants that are not breastfed, are they just as healthy as the ones that are, or is there something medically stopping them from being able to be breastfed? Because they already have that.
Right.
I wondered that question also.
And there are certainly confounders here for sure, because, and we're not talking about just once. I mean, ideally, it is the establishment of breastfeeding before they are discharged. But certainly, premature babies, for example, very low birth weight babies, or babies with other sorts of issues may well, have a longer lead up time before they can learn or be effective breastfeeders. So it is complex, but the data nationally certainly suggests this is a protective factor, even if we don't have all of that within Maryland.
Yeah, because I sort of share when I saw the chart, I had the same reaction. I want to be cautious about whether saying it's a protective factor because of this data as opposed to it's a protective factor because of other data.
Protective factor because the literature establishes it. I don't know if the literature establishes this level of a gap, though. Does it?
This is a significant gap. There are racial differences, in particular in breastfeeding, that are worrisome and something that we considered both in the work group and the literature to be something that was worthy of further attention.
Pregnancy spacing.
So this is going to have all the same problems with approach. But this was again a factor where the discrepancies were quite large. So, yep. So turning to key findings, what we see is that over time infant mortality rates have decreased, but disparities persist. And regardless of geographic area, African American infants have consistently higher infant mortality rates than other groups. Again, those different trends in the rural areas. And that is true also regardless of the risk factors we studied, that the African American infants always have a higher risk, which means there's no one risk factor of the ones we studied that we can pull out and say this is why that's happening, which we wouldn't have expected. But and then one thing that the University of Maryland team did was they did extensive research on programs that are related to infant mortality in the state and created a program inventory. So we know based on their research that there are more than 81 separate programs that operate in the state that are focused on infant mortality, either providing direct service or doing research, epidemiological research, and that doesn't include all the MCO programs. So there's a significant amount of effort in the state focused on this issue. So based on the literature reviews, the program inventory, interviews with experts, the work group work, and the data analysis, we've come up with a set of 14 recommendations that are arranged in 3 themes. Those themes are care coordination, expanding and enhancing the access and utilization of services, and a need for a sustained and centralized focus on infant mortality. That third theme is about specifically addressing that requirement in the statute related to a permanent counsel. So turning to care coordination, we have recommendations related to improving existing care coordination processes and tools. There are already tools that are in use and other tools that are available on the market. And so it's about making sure those tools get put into use and used effectively. And that information is shared between different medical and service providers. We think it's important that care coordination include programs to address social determinants of health, including the impact of racism and bias. And one recommendation is about, we think it would be important to have training on implicit racial bias for healthcare providers and staff who interact with mothers and young families. In addition, we recommend strengthening assessment and referral to behavioral health programs, improving continuity of care, particularly at points of transition. So when a woman's transitioning from primary care to OB care, when the family is transitioning from the pregnancy and prenatal care and pediatric care and postnatal care. This is also an issue of insurance, of making sure that people who transfer insurance during some stage in that process also get all the help they need to do that. Medicaid in Maryland ends 60 days after the end of a pregnancy for women who are eligible due to the pregnancy eligibility category. Most women who are eligible for Medicaid during their pregnancy remain eligible for Medicaid after that time period, but some number of them need to transfer on to the Maryland Connector and private health insurance. So just making sure they have the support they need to do that smoothly. And then we have a recommendation about increasing adoption of breastfeeding and making sure that the whole healthcare community is focused on the importance of pregnancy spacing. Okay. Turning to the theme on expanding and enhancing access and utilization of services, we recommend expanding home visiting programs, as the literature showed that they're particularly helpful in improving maternal and infant health outcomes, increasing adoption of evidence-based group prenatal care programs. It's a different way of offering prenatal care where moms come together in a group facilitated by a healthcare provider. And so it creates both social support at the same time as providing healthcare. And then enhancing the use of telehealth in rural communities. There was some evidence in the literature that there was strong evidence in the literature that use of progesterone is important for women who have previously had a preterm birth and preventing future preterm births, and that adoption of that in the clinical space has not been as strong as we'd hope, so we included a recommendation on that. We also have a recommendation related to health literacy and a recommendation related to safe sleep education, but also safe sleep resources. There's evidence in the literature that for some families, providing an actual crib or a pack and play, a safe space for the infant to sleep can really be very helpful. And then finally, we have right now a draft recommendation related to establishment of a permanent council. This is something we've talked about in the work group a couple of times. It is mentioned in the statute, but I think there's strong feelings that a intense focus on disparities would be helpful, and also a sense that we don't want to create a new entity that pulls resources that are currently being used for operations and delivering care, or that otherwise stretches resources. So the question is, how do we bring the focus that's needed to push the needle on this issue while working within a limited funding environment? So I welcome opinions and input on that as well.
Comments, commissioners?
Great work. Lots of perspectives on this. I come to this with a unique perspective. I used to work for Chicago, which is an international women's health organization, who went out into the field and sought to improve the lives of women and their children. One of the things that I went to actually go view in Nigeria, and it was startling to me on why the approach was done the way it was they used community plays to act out a situation and to explain why it was important for the mother to go immediately for health care versus waiting and what could happen. And it was done purposefully because it wasn't to educate the woman who was pregnant. It was done to educate the community around her, because it was the community around her that was going to get her to where she needed to be. And I look at studies and I see how people communicate. And if you look at the African American community and how they communicate, who they trust information from, who they don't trust information from, it is very clear that they trust information from their family members. It is, well, I'm going to do it because this is what grandma told me to do, or this is what my mom did, this is what my aunties do. They have experiences with the medical community that they'll have a complaint of a symptom, they'll be ignored, and they'll just walk away, because nobody's listening to me again. They also have a perspective of strength, that I'm going to be okay. Despite all of this, I'm going to be okay. So changing the way we communicate to those communities is what's really important. And to me, that is the #1 thing that we need to get out of here as a theme. That if we're going to expect somebody to use a pack and play or to do breastfeeding, et cetera, we don't tell the woman who's pregnant, we tell the community around her to validate that idea and to perpetuate it through generation and generation. I think, again, I thinking back on my pregnancy, I learned and I changed behavior through guilt. I don't think that works in this situation at all. I think we have to completely change the paradigm and work towards the community, not towards our perspectives of what the pregnant woman should do, who's already under a large amount of stress. We don't want to put her under any additional stress. So that's my recommendation, to be blatant about it, bring it very up to the very top and say that to communicate in a holistic way. And we do have practitioners, not just from the University of Maryland, but from Johns Hopkins and others who have gone out into the community, have implemented this, and there's plenty of evidence to show how this works and why it works.
Yes, and I was at just to echo that, and then I was at an event that Baltimore City put on where they brought in national researchers on to talk about breastfeeding, and they were specifically talking about the importance of a woman's social network and how having even one advocate in the woman's natural social network, so not the doctor, but someone who's a friend or family member for an activity like breastfeeding makes a tremendous difference. So, yeah.
Mr. Thomas.
So, for me, when Serena Williams, who clearly is famous, money, and almost died in childbirth, okay? That ripple effect has consequences in the minority community. Many of my young African-American graduate students are like shocked, thinking that simply because they're a Black woman, their baby is going to have increased risk of dying. I don't think there's anything in this report that says there's some genetic dynamics that never came up, that these are social, cultural, as you've just mentioned. But if our recommendations sound like more of the same, we might not reach this audience. So I would hope we could give this group permission, freedom to think outside the box, so that maybe fathers have a role to play. You think dads might have a role to play? Some dads feel that all those maternal child health spaces exclude them. They don't feel welcomed. I think we should address that. Because how's that young one going to have support when the father feels alienated from that setting? The other is, even if we have home visits, they've been around a while. Social support groups, they've been around a while. Telehealth, okay, we're not going to do it on the computer. You still need cultural tailoring. You still need to listen to that audience and redesign, reimagine, and give them a message that's tailored to that cultural context. That's what I'm not hearing yet. We should give them permission to explore those things. They could meet the letter of the mandate and we'll still be where we are. Give them permission to think outside the box and come up with some really innovative ideas for us to consider.
I don't think they're asking for permission, and I don't think they need our permission. I mean, they had a mandate to go forward and look at this issue.
Yeah, the mandate can still keep you inside the box.
But can't. I'm just saying they haven't done that. So to encourage them to do it, I think is a good thing. Also, that's part of the reason why, to Andy's suggestion about, we need a multivariate, not a univariate approach here, is how do you, I can think of a real world example where we were doing the uninsured at the federal level. And if you just looked at it one variable at a time, you took away one message. If you looked at it and said, well, what industry they're in, what size firm, and some of these things it went away for some racial ethnic groups. It was more where they worked, in agriculture, nobody had good coverage. So it was, the policy had to take care of small business, especially in some things. In other ones, there was still a racial ethnic context to it. So you needed to look for a cultural or whatever. So that's why I think definitely we need that. I did want to speak to this. They need a permanent group. I guess my experience in permanent groups is, are they to be an advocacy organization within the establishment of the state government? Or are they to be an analytic group within the state government that doesn't necessarily have an agenda, but does have a task that they're charged with looking at and coming up with policy options for the legislature and the governor and things like that. So I'd have to say that in my experience, the ones that view themselves as advocacy within the administration are, if nothing else, seldom effective, because their colleagues go, you're always asking for more money for your pet issue. The ones who are the resource in terms of what does the data show? What could we do? What is the latest thinking out there? What have the other states done as best practice? That I could maybe get behind. This sounds a little bit more like advocacy, in-house advocacy. And I can't tell you, I'm overwhelmed by that.
I worry that, I think there's tremendous value to highlighting this problem overall, but I worry based on what we've seen before that we're replacing careful scientific investigation with the data mining that we're able to do given the data set that we have. And I don't know what that provides that's of value more than a detailed literature search provides. In other words, literature provides that breastfeeding is a problem. What are we doing? We're just confirming what the literature shows?
Yep.
In an incomplete fashion? How's that helpful? I think that trying to identify how we can improve infant mortality in Maryland by implementing things that are known, identifying the gaps, and identifying our ability to fill the gaps based on the information, the robust data set that we have in the state is valuable. And once you find those gaps, that's an R01 right there to fill the gap. We don't have to look outside for funding. There are agencies that provide that funding already, provided we have a methodology that's sound.
Mr. Chair, the unintended consequence that we should always be reflecting on is this is a slippery slope to something wrong but me as a mom. Self-blaming. And they're so vulnerable to that I've done something wrong and my baby's sick, or I've done something wrong and my baby died. That's not the take home we want.
We want to get the take home before that happens. Right. We want the take home to be, this is what we want to do so that this rate comes down, not individual blame by any means.
Right. If there's anything to bring people together across all that we might think divides us, is ensuring that babies die beyond the first year, live beyond the first year of life.
Is there a way to marry the data mining you've done here with the established literature in the report so that you don't have to decide that breastfeeding is a really important factor based on this chart? We saw this, we went to the literature, we see that it is in fact an important factor. We make recommendations based not just on the data report, but on established research. That makes sense.
Yeah, I mean, the factors that were selected for data analysis it was kind of the reverse, where we looked at the national literature and looked at the data we had available in this particular data set and looked at which we could analyze, right? So that leads us to a smaller set. But do you want to?
Yeah, I mean, I think the other thing here to remember, and we know this is part of why we wanted to see this now, because it's a complex report, is that it was the literature, not just the literature on risk factors, it was also the literature on what are programs that would work and don't work. So looking at the evidence base for programmatic initiatives to prevent infant mortality, looking at what we're doing in the state of Maryland now, because if it's there, I think one of the things we really sought to do is say, how can we make things work better and differently than we have? But the other thing we did in interviews we did interviews with people around the state. And so we also were really cognizant of what are some of the things that we know work from the literature, address risk factors that are identified, and address some of the gaps that we heard in interviews and we saw in the program inventory. So that we really were thinking kind of beyond the data analysis was one important part of it, but also what do we see happening on the ground and what are people telling us are the gaps and ways, and those things all came together to help us formulate the recommendations. This is complex, and I would go back to, we certainly hope we reflected the importance of the broader community and family and social support system in the recommendation, and we will double check back and make sure that comes clear. But I think the other thing that is, and part of why the work group particularly was interested in this, was that there is a linkage. There is an incredible disparity in maternal mortality, and maternal complications of pregnancy is one of the causes of infant mortality. So it's hard to separate them, and that's why we put it forward for your discussion and consideration.
I have one last question. So the recommendation for telemedicine for people in rural areas struck me again because it always comes up. And I guess the question I have, being a suburbanite myself, I wouldn't know. Is recommendation more telemedicine for rural areas something that folks living in rural areas are in their homes saying, I would like more telemedicine? Or is it a sort of urbanite's view of what rural areas need?
I would, you certainly heard lots of concerns about, we know that the workforce of OBs is low in some of these rural counties, and so that means long transportation times for moms to get to prenatal visits. So I think that's a place where it just sort of makes some sense. What we heard from urban areas is that they need telehealth too. So that it was not your question, but there are still transportation barriers and barriers on people's time, and telehealth sometimes makes things easier.
I just want to make sure we're not using it as a panacea. Oh, those folks live far away. Let's give them telemedicine.
But I don't want to hold us up to, but telehealth first came in maybe 10, 12 years ago. And the places that it actually started to take hold and work, like the Indian Health Service uses it a lot for like Alaska, and you can imagine. And then they were sort of surprised. It works really well for kind of counseling and mental health things. It was really good in trauma where you had a medic on site, sort of a, but the chainsaw accident. And it's sort of where the best case, the return on investment, so it started in rural. And so it's big in kind of rural health policy to think about some of these things, especially where you've got these things where, Medicare is getting tired of subsidizing hospitals that only have 50% bed capacity, but there's no other hospital for 50 or 100. So the same way that they want to use helicopters a lot, telehealth is, it started out as one of those happy talk panaceas. And then as they tried it, it worked. The more rural you were, the more it worked. I don't know that there's a good set of evidence that says you need it for anybody within 20 miles of each other. But like I say, Indian Health Service, reservation work, that kind of stuff, it certainly has proven worth the investment.
If I may, going back to your question or your point, I believe we actually did think, that part of this then is whether we're talking about Wycomico County or Allegheny or Garrett, is what, as Megan said, what do we have on the ground as infrastructure in terms of care? And, how might this be a feasible option? And so I think it would require some consideration of what do we know, what do the providers in the county know, and what does the community in the county think of what's the acceptability of telehealth services? So, I think it certainly speaks to needing to do some homework in that regard.
So I just wanted to turn us back to the permanent council. There was at one time in the early 90s through about 2003, I think, permanent council, a council on infant mortality that primarily served as a convener function. Didn't have a lot of funding on its own, but brought participants together on issues of infant mortality. I think permanent council should, one, be recommended. We take on some of those roles. There are lots of models on issues of the state. Creates high-level ribbon type councils that brings together the programs in the state and looks at how they work, not necessarily. I actually think we have plenty of research resource capabilities. There's probably some need to organize them a little better. I think there is a host of programs, but maybe not as effective cataloging on the effectiveness of those programs. So if there was a permanent council, I wouldn't think that we want to invest significant funding in it, but we would want to say we want to invest significant authority on it. The stop, press the accelerator on things that work. It does seem, when I look over the last 20 or 25 years, that in infant mortality was a focus. We did make some improvements on it, but other priorities come into play and take greater priority and things kind of slip. I think there's a concern now, particularly in rural areas, as we see somewhat the evolution of the healthcare system, to be concerned generally about rural health, particularly about minority populations' access to health in rural areas. That does warrant some additional attention. So adding some additional credibility, be it chaired by the Lieutenant Governor, by the Secretary of Health, whatever, to bring together the resources. Keep in mind, sort of the CHIPS, prodding comment, which comes up here. The Healthcare Commission is not the expert here. In fact, there are 3 or 4 qualified organizations within the Department of Health that could have taken it on. The Bureau for Mothers and Children, the Office of Vital Statistics, the Office for Minority Health and Disparities, but no one really wanted to do that. I don't think we're the permanent council, but I think that there is a need to bring together not only beyond healthcare, probably transportation, agriculture, environmental services, to focus on all of these issues periodically and benchmark our performance as a state, where everyone that can make impacts can be brought into the room periodically. I wouldn't say it's something like I remember, and David Sharp and I sat through many of these meetings with the state staff, where monthly state agencies were called on the carpet and asked to report, and statistics changed by minor numbers, but everyone flew into a tizzy. That sort of very, very specific and redundant effort is not what I'm talking about here, but I am thinking about a semi-annual or maybe an annual bringing together of the governor's leadership team to talk about this with the participants that can move the needle is something that would be credible. I think one of the things that we're really sticking our nose under the empirical science of all of this. I don't think we're going to have much make much more headway on that over the next month than we have today. But that's an important suggestion. I think that we heard from a couple people that some agency needs to take a look at. And, but a permanent council, blue ribbon council, highlighting the importance of it, not doing it, it's one way to push that along.
Mr. Thomas.
Very quickly, again, every year the state has its health equity, minority health conference. It's huge. It brings practitioners, scientists. It's the one thing that is that diverse. Yeah, but a topic like this, complicated, maybe that this should always be one of the themes at the annual state minority health conference. It's coming up. I don't even know if this is on the agenda. Yeah, shortly. It's like right around the corner.
It's in December,
You know, you guys run it. I mean, it's a state conference. And so taking advantage of what already is here, that happens every year. It should be on the agenda of that conference in a way that is convenient.
No, I think that one thing that I can kick myself on is I can't answer the question I asked myself at the start. How much are we spending on this as a state? We've done a good job of cataloging the programs, but what's the budget? As someone said, our budget is our priorities. We ought to be able to say that.
Thank you, ladies.
Well, just final. So Ben, you're saying that you don't think we'll be able to see a multivariate analysis by next month? Is that off the table?
Well, we're definitely going to talk.
Really
I mean, I don't think I would say this. And
Well, they have the data. I mean, it may collapse some years, your same problem as before.
Yeah.
But they, all these different independent variables they showed us should be in a thing.
That many.
Well, there's
So-
5 or 6.
We'll talk to our colleagues. We lost a valuable data analytics resource on the collective team midway through the study, so that's part of what's happening here. But we'll talk to our colleagues and see if we can get that done.
Commissioner O'Grady, when you're talking about the data set that would be rich enough to address some of these.
Need more than 4 or 5 variables.
I'm not sure I mean, we have the vital statistics data, but.
Well, we have some, what I'm saying is mostly what they've already got, which is those other tables.
Right, you're
So-
talking about doing a multivariate.
I'm just talking about
analysis on
using the data
factors
you've
we've already
already
looked
got
at.
and
Yeah.
doing a multivariate.
Sounds like you're talking about factor
But I-
analysis.
Yeah.
No, it's not factor, it's more rigorous than factor analysis. But it is controlling for the effects of these other variables
Yep.
and then being able to say, okay, what is breastfeeding when you control for all these other things, that table 2 through 7.
Yeah.
I'm just saying, I have trouble going forward with a report. I don't know that I can support a report. It takes it one variable at a time when we just, it's liable to be more
You just have to
misleading.
declare this is one variable at a time. It's consistent with natural literature, but it really doesn't say anything other than it's unlikely that the Maryland data is substantially different than the national data.
If you're comfortable with that, but I'm just not.
Yeah, I just don't.
We're not done yet.
It depends on right. It's a start. You just have to be my point was just to be very careful to couch it for what it is, not what it's not. And to take 4 or 5 variables, you get 1 or 2 of them that'll have significant differences that you can use in a regression model. That's not enough. It really isn't. To get you have to figure out what this may be related to. You have to start postulating what it actually
Right, but this methodology allows you.
Not what do we have, but what might this
You
be a
may know
marker
that you have 10 things you ideally like to look at, and you only have 5 you can measure. But that's head and shoulders above only measuring 1.
Right, but if you've only got 5 things total.
Right.
And
then you don't have the overall power of the model. You have to say, well, we only explain 50% of the change.
This is much better than just saying.
There's a correlation between breastfeeding and.
Yeah.
Right.
Yeah, I get that.
Yeah. A 1 variable model is much weaker than a 5.
Yes. Unless it's the only significant variable. Yeah. One bit variable, right?
All right, we're starting to.
Well, if we don't run it, we never know if it's a good
To
variable.
drift.
Agenda number 9 is the very brief overview of upcoming. We start the
Here
clock.
the discussion in very briefly for October. We're looking at a CON review. Several more certificates of need pertaining to drug treatment. I'd like to have a number Hospital, CON. We'll be bringing back this study, looking at what we can do in a span of really 3 weeks, because the mailing is 3 weeks. We'll try to do the best we can, qualify what we can. We are committed to bringing final action on the school health recommendations, which my takeaway from that is you want them more specific and a little more meaty. And we have some announcement information that's going to be, we're going to highlight some planned telehealth grants that we plan to release over the next several months. So I think it'll be a pretty good meeting in terms of try to keep it to the allotted time. And as I mentioned, we would spend some time during our additional hour talking about the budget for 2021. So thank you all. I did want to respond to Commissioner Gordon's point. I think some people echoed it. What he said, the commission sometimes gets work that no one wants to do, not because the legislature just wants to dump something else. It's because there's a tough issue and they need someone to get it started. And oftentimes we don't always come up with the answer the first time around. But I think the commission is viewed as a fair and impartial platform on which everyone gets to air their opinions. I went into David's telehealth meeting saying we got to get this pushed into to the Department of Health because this is really health. But I was quickly met with rotten fruit, and I found out that actually the Department of Health was not all that enthusiastic about it. So there's a lot of subtleties in some of these work groups that go on. And it may seem to the commission, why do we do this? But it's oftentimes that you all are so respected that you the legislation has.
The General Assembly wants to know what we think about this stuff. They expect us in a relatively unbiased fashion to review the materials, to make comments, and to provide some perspective. And sometimes it's cover for them to be able to get to an answer legislatively, and sometimes it's support for what they want to do, and sometimes we just add to the total chaos and confusion.
Wouldn't you say there is a degree of trust we've earned over the years?
We're careful in our analysis of things. All right. I will, at this point, entertain a motion to adjourn. Any opposed? Hearing none. Well, I will take a non-unanimous response.